Welcome everyone to this afternoon of information sharing. Beautiful day outside, wonderful day. You won't be here too long. It's a nice compact program. And just to start off with something left field, this morning when I got up, beautiful day, and after doing my usual thing on a Saturday morning, I started to read this article about the famous Henry Kissinger, who was the Secretary of State under Richard Nixon and under Gerald Ford. He was quite a controversial figure, quite instrumental in world affairs. But they were doing an interview with him, and a German newspaper was doing an interview with him on his 100th birthday. And he was as sharp and insightful as you could get anyone to be. His insights into world affairs, the Ukrainian conflict, artificial intelligence, everything is, and he says, I'm not sure whether he was joking, he says he still works 15 hours a day, So it was just inspiring, even though he was never my political ally, he was quite a right-wing person, quite a controversial character over some, but it's just fascinating and inspiring really to read this guy's thoughts in this interview. It was word for word, as clear as anything. So I offer that to you as an inspiration for your ongoing work. And of course, as we all age, Now, as far as the program today, it's a nice compact program, great topics, with a wonderful Antonia Shand, who leads our MFM service, puts heart and soul into it day and night. And she's accompanied by Sarah Lyons, a newer staff specialist, who is equally committed, clearly helps out in MFM and general obstetrics. So they're wonderful people to have, and I'm sure you'll learn a lot about the important initiatives around first trimester screening and preterm birth. Then the important subject of neonatal birth trauma from Dr. Williams, again, a very important area. And then after that, we've got the physios talking after afternoon tea about pelvic floor issues. And I'd have to say our physiotherapy department here is wonderful. They are up and at 'em. They're always thinking about what new things we can do. How can we do it efficiently? How can we serve these women in the best way? And they are always onto it. We had a wonderful talk from them the other day at our Tuesday evening meeting, where they spoke about dealing women with various musculoskeletal aches and pains, which can become quite a task during pregnancy, about how we can do a bit better than just admitting them, doing a series of investigations. They were proposing a very intelligent system of simply keeping them at home with some specific advice and clearly physio evaluation. So they are one of our true assets along with the MFM department, all right? As far as a few things about GP shared care, things of relevance to you, our birth numbers are going down, quite noticeably so. Why? Not sure. Most of us think it's an economic phenomenon. This is an expensive area to live, but it's quite noticeably down. Clearly, it's happened to the other inner city hospitals as well, and that impacts all our work. Just the basic demographic here, the age keeps going up. Perhaps 5 or so years ago, when I looked at the average age, it was 32 of birthing mothers. Now it's 34. And the most noticeable grouping there is the women above 35 who are birthing. They constitute about, I think, 40% of our birthing women. That's quite a significant, demographic change compared to previous eras, and it makes a difference to outcomes. Now, as far as just a few procedural things, bookings will be returning face-to-face. When's that end, Chantel? Bookings returning face-to-face, that's happening now. 1st of June, all right? So that's an important change. The midwives are very keen on this. We're very keen on it as well, because of it just doesn't, while the virtual bookings have been served a purpose, really there have been various deficiencies that have arisen in our evaluations with that means. Just advise you that syphilis screening is happening now twice during the pregnancies because of the concerns about rising incidence of syphilis. The other thing is that we request that you give the results directly to the women so they can bring them to us. We're asking not to fax them to us because it's just not manageable. Results get lost. Yes. No, yeah, yeah. Now, I do, next to that, I do acknowledge there are major problems with our written communications, mainly because, we use e-maternity and then you guys can't, log into that. And we're trying every which way to, make that happening, but it's a challenge. Remember that a group of us worked on that for 3 years. We got nowhere. Right, it is a major challenge. So I just want you to know that's what we want, and as soon as we get a breakthrough, we'll let you know. As far as obstetric and neonatal placements, which used to happen, they've been recently given the green light to go ahead, and we'll keep you posted about that. Just briefly on other fronts, we have got a whole project about revisioning birth, pregnancy care and postpartum care. And a lot of that centres around, trying to do better on the continuity of care front. We'll keep you posted about all of that. I remind you that our interventions in birth keep rising. There are lots of controversial points around that, and perhaps one of the ones that's quite controversial still, despite various bits of evidence which people interpret differently, is induction of labour. That's increasing. Now, amongst the very good things that are happening here, there's a whole simulation education initiative being spearheaded by Siobhan Lee and Amanda Beach, and it's just fantastic. They are finally making multidisciplinary education happen so that midwives and doctors are working together, and that's fantastic for the women. And then, of course, Siobhan, with her strong GP bent, will make GPs involved as well. But that has been wonderful. We've got a great simulation set up here. And so I just emphasise the multidisciplinary education as well. Look, the other challenge is that dealing with the traumas that happen, that women incur during birth, and dealing with the the fallout from that. That's quite a time-consuming exercise. And we do want to see these women who feel traumatised or very hard done by in their birth and are being affected by it. We do have a setup to deal with this, but it is a challenge, all right? Anyway, enough said from me. We'll proceed with the program. Thanks very much for attending, and I hope you all enjoy it.
Good afternoon, everyone, and welcome to the Antenatal Shared Care Royal Hospital for Women Obstetrics and Gynaecology update. I am Elizabeth Ailiff, one of the Royal Hospital for Women antenatal GP advisors, and I will be introducing the speakers. Today's event has been RACGP accredited for 2.5 hours of education activity. We will submit your CPD activity hours with RACGP on your behalf. 5 antenatal shared care points have also been allocated for this activity. For those of us joining online, you will be able to submit questions via the Q&A tab. Please note that we will try and get to as many questions as possible at the end of each talk. Just a couple of housekeeping features. Please turn off your mobile phones or place them on silent. No eating in the lecture theatre, please. Please wear masks unless you are eating. There are toilets located on each floor. Afternoon tea will be served at 2:20. Now I'd like to introduce our first speakers of the afternoon, Dr. Antonia Shand and Dr. Sarah Lyons, who will be presenting first trimester screening and preterm birth collaborative.
Thank you very much, everyone. Now, I was not out thinking like Andrew was this morning. I was out running Parkrun, and I have to say Parkrun is a fantastic initiative. I'm very grateful for Parkrun getting me up this morning so I can live to 100 perhaps. So thank you for having me. It's been great to actually talk to some of you at lunch, and we will be here at afternoon tea. And it's just very exciting to talk to a number of you about a range of different things that we're interested in. But today we're going to talk about screening for aneuploidy. And I've got a few scenarios that we're going to go through. And then Sarah, who's running the preterm birth clinic, I'm just delighted that she's A, doing that, and B, coming to talk to you as well. And then we're going to talk a little bit at the end about some of the things that we've got changes in the hospital that we're working on, because some of our fantastic midwives are here and working on some great initiatives as well. So we'll go through that. So I think this is well known about screening for aneuploidy. My nephew turned 21 recently, and he was screened as a baby, as a fetus in London with first trimester screening. So the age-related risk of fetal chromosome abnormalities has been known for a very long time. So there's an increase, particularly in trisomy 21, trisomy 18 and trisomy 13, all with maternal age. In comparison, the sex chromosome aneuploidies don't particularly change. And you can see up here at the age of 40, rule of thumb, 1 in 100 at age 40. So this is well known. And I guess what's changed over time is we were doing age-related screening and women getting amnios if they were above a certain age. And then we moved on to second trimester or serum screening, then nuchal translucency, as I said, over 21 years ago. Then additional ultrasound markers, including nasal bone, tricuspid regurgitation, and then we've moved on for non-invasive prenatal screening. And these screening programs were really designed around trisomy 21. However, trisomy 21 is only a small proportion of what we're actually screening for in the first trimester. And I guess if you overall think about what is the rate of congenital conditions, previously called birth defects, but 97% of babies don't have any congenital conditions, but there is this 3% in here that do have a condition. And so chromosomal, it makes up a small proportion depending on the age of your population. Obviously in our population here, where we are above the national average in age, as Andrew said, median age at 34, that will be higher, so 10 to 15% of chromosomal. A small number will be prenatal exposures. One of the projects I'm doing at the moment is looking at retinoids, so oral retinoids in reproductive age women, and what percentage of these women are co-prescribed contraception. And actually it is frighteningly low, particularly in the low age groups. So Mother Safes gets a number of phone calls every year about women who have taken retinoic acid, which is a known teratogen. And I guess Mother Safe is constantly getting calls. And we were talking at lunchtime today about what is the access for women of having long-acting reversible contraception, having GPs able, trained and confident to prescribe and dispense long-acting reversible contraception, such as Mirena, in terms of rebates plus training and access for women. But we continue to have a number of prenatal exposures that are somewhat preventable. There are obviously some single gene disorders, and I don't know if some of you might have been recruiting to Mackenzie's mission and have seen the preliminary data. So the preliminary data from Mackenzie's mission, where they screened about 10,000 couples around Australia for 1,000 different genes. They screened both members of the couple, looking for genes that were the same, and 2% of couples were found to carry the same mutation. So not surprisingly, that 2% of those 1,000 conditions, some of those children will have a congenital condition. And I think the sobering number also from the preliminary data from Mackenzie's mission was that 18% of couples who were consanguineous carried the same mutation, or sometimes multiple mutations that were the same. So there has been announced that we're going to have rebates for screening for congenital conditions like cystic fibrosis, spinal muscular atrophy, and fragile X. And that we've been told that it's going to be happening in November this year. There's a lot of discussion about how ready is the workforce for that, and whether we would be actually offering screening for other conditions as well, because it's apparently not that much more expensive in terms of the lab expense. So there's a bit of discussion going on in the background. And then there's multifactorial, and then there's unknown. So just thinking about when we're talking about non-invasive screening and nuchal translucental screening, that chromosomal is actually a small proportion. And so the screening paradigm has moved from first trimester screening with nuchal translucency plus or minus bloods to non-invasive screening. And I guess both of them are screening for these common aneuploidies plus or minus the sex chromosomes, but they offer slightly different things and are actually very complementary. So I guess with first trimester screening, you get viability and gestation. You get a large number of structural abnormalities are now detectable in that first trimester. Twins and chronicity. Obviously, chronicity is extremely important in terms of pregnancy outcomes and need for surveillance, and the role of preeclampsia screening. I guess with the NIPS, a lot of people are very interested in the sex of the baby. The other question is, should you be screening for sex chromosome abnormalities? And that is a debate as to the role of that. And I guess my view is that for some people that is very important information, but because you can then think about, well, what am I going to do with that information in terms of a follow-up plan? But they have both over-detection and under-detection rates, which we'll go into. Rare autosomal trisomies, if you are moving to doing extended chromosomal analysis on the non-invasive screening, the more you look, then the more you will find things, but the clinical significance of this can be difficult. So, and then the next question is, should be doing microdeletions and duplications. And what about triploidy? So I guess first trimester screening has been around for a very long time, using these combined risk factors, ultrasound, serum markers, and nuchal, nasal bone, heart rate, and other markers. And as you know, that this comes up as a test result as 1 in something. 1 in 100, 1 in 200, 1 in 300. The worst you can get is 1 in 2. And the detection rate is around 90%, or if you do multiple markers, up to 95%, with a little bit less in twins. So we do a bit of first trimester screening in the maternal fetal medicine department, not as much as some other maternal fetal medicine units because we don't have the resourcing. But what we're looking for is this nuchal translucency ultrasound. And the well recognised in Down syndrome, the skin is deficient in elasticity or too large for the body. And this man down the bottom is actually Kypros Nicolaides, who is a professor of maternal fetal medicine in London, who's pioneered this first trimester screening. This is just showing you the gestation-specific reference range for nuchal translucency, which increases with gestation. However, when you actually do screening for first trimester screening, obviously what you can see is a lot more than just the nuchal translucency. So here we have the crown rump length of a fetus, which will be somewhere around 5 to 6 centimetres. And you can see that the skull here looks markedly abnormal with anencephaly compared to a normal profile. Here we have a normal brain with this sort of, both sides very symmetrical, and here we have hollow prosencephaly. So the first trimester ultrasound will give you a large number of lethal abnormalities that can be detected at that stage. And these fetuses do not need non-invasive screening because they don't have a chromosome problem. They have another lethal problem. So, and I guess that's the issue when you do your non-invasive screening first, that your patients are paying for a test that actually is not going to help them because it's not the same thing. So this is just a meta-analysis about what can we detect in terms of first trimester screening in that scan. And the machines are so much better now than what they were. We still actually don't know the numbers. This is really the protocol to determine that. But if you think about, I've just got some of the things like anencephaly. You can see all anencephaly. It's lethal, it's rare, but you can see all of it at 12 weeks. You can see holoprosencephaly. Again, it is just obvious. It's lethal. Severe ventricular megaly, hydrocephalus, not always, but for many cases you can. But these critical heart problems. So if you send your patients to a good screening practice, hyperplastic left heart, most of them are lethal. We can see them make a diagnosis at that 13, 14-week mark. Things like gastroschisis and omphalocele, you can see them. Bilateral renal agenesis, things like lethal skeletal dysplasias and these obstructive uropathies, again, easy to see. So with this, with the structural scans, many of these abnormalities will be detected. And ideally, if you can do it 12, even 13 weeks, you get better images. The fetus it's getting bigger, particularly for heavier women. Although technically you can do it 11 weeks, it is harder to see some of these things. The non-invasive screening has been around for a long time, testing fetal DNA in the maternal circulation. But you've got to have an adequate fetal fraction. So gestation matters. So if you do it too early in a woman who's heavier, you will find that you might not get a result. So the later you do it, the better you are likely to get a result. Also, if it's abnormal, you may not get a result. And also the sample's got to be adequately stored with the right tubes. And I think we see a lot of women and they come to us and when they get a result, the question is, does that mean that the baby really has the clinical condition? And it really depends on what the background risk is. So, we know that non-invasive screening picks up over 99% of cases of Down syndrome. But when you actually have a woman with a positive non-invasive test in front of you, the question is, that is not 99%. It really depends on what her background risk was. So if you have a 16-year-old woman with a normal structural scan, her risk of having a fetus with Down syndrome will be much, much lower than you've got a 41-year-old woman where I can see there's an AVSD. And so, which half of fetuses with an AVSD, which is a major cardiac abnormality, will have Down syndrome. So when we see these women, it really depends on what the scan looks like. Trisomy 18, again, this positive predictive value is just over 50%. And this is really, and the trisomy 13, it's only 25%. So when we see these women, we really want to scan them and have a look at what their fetuses look like. And this is why it's very important that you don't say just have a termination of pregnancy, because many of these fetuses will be normal. And our job is to try and work that out in as quick as time as possible through either CVS or amnio. And these sex chromosomes, again, it performs poorly in terms of the positive predictive value. There are many different brands on the market, and they will vary in terms of what test, what your turnaround time, a bit about what the cost, a bit about which what you want to do in terms of additional testing. So I think it's, in terms of which brand over another, I still think that the main role you should be doing is 21, 13 and 18, and then discuss with women about whether they do or don't want to have sex chromosome testing done, or whether that would be something they would want to know. In terms of looking for whole genome, I think that is, we're not there at this stage, and also micro deletions, because the more things you test for, the more likely you are to have a false positive result. But what the patients are thinking about is, is it a boy, is it a girl? But I'm sort of thinking about, all these other things. And when I get my test results, what am I going to do with all of these things? In terms of doing CVS or amnio, so CVS we can do really up until the time you can do an amnio. You can do an amnio from 15 weeks onwards. For those of you who haven't seen an amnio, it's a very straightforward test in terms of under ultrasound guidance. It takes about a minute. You put the needle in, it's a 22 gauge needle, you take 30 mils of fluid. It's a very straightforward test with no local anaesthetic. and you'll usually get your fast result the next day and the array within around 10 days. For a CVS, you can either do it abdominally, or less commonly we would do transvaginally and putting the needle into the placenta with, again, similar turnaround times for the testing. So this is the algorithm that we've been using at the Royal in terms of which test to do. And still our recommendation is to do first trimester screening first, look at structural scan, then decide what you're going to do and whether you're going to do a NIPS, whether you're going to do no further screening, or whether they're actually in the high-risk group because they've got a high-risk screening result, or they've got a big nuchal greater than 3.5 millimetres, or there's a structural abnormality, or you can't get a NIPS, and then refer them for genetic counselling. And we have genetic counsellors working in the department every day of the week, and they will be very responsive to your calls if you've got any uncertain results, abnormal results, and we will usually see them within a few days, and everything is bulk billed for patients who want to have invasive testing or not have invasive testing if they choose, because we try to give people the choices. This was a study that we've just had published, just talking about some of the perceived benefits and harms of non-invasive screening. Some of the benefits, obviously, it's way more accurate. We are doing fewer invasive tests. We are reducing the risk of miscarriage because we're doing fewer tests. And these are, obviously providing additional reassurance and decision-making, knowing biological sex and bonding. But we occasionally have cases where there's been no anatomy screening done until they turn up with their 19-week scan with a lethal abnormality that could have been detected some weeks before. And people saying, oh, you don't need to have a structural scan, really. The false positives, it certainly creates a lot of anxiety and, low positive predictive values, and potentially unnecessary invasive testing after false positive results. Obviously, it can do false reassurance and the anxiety and distress. And I recently had a patient who requested termination of pregnancy because she felt so traumatised after the high-risk non-invasive screening result she was given. Well, they couldn't get a result. She had a BMI of 30, so they couldn't get a result, and then she had a redraw, and she also had a high-risk first trimester screening, and she was referred to another maternal fetal medicine unit, and she said she just felt so traumatised she couldn't bond with her baby. She requested a late termination of pregnancy and had a termination at 23 weeks. And I think it's just tragic that happened to her. She obviously had a lot of psychological distress in her life before, but there's no, that is at the extreme end of the spectrum, but that was very upsetting. And I think our genetic counsellors do an amazing job. Us doctors, less so. And so you really want them to actually talk to the families about not just what the test tells you, but how do you feel about it. And she was not offered that at another centre. So here we go. Here's some scenarios to wake you up. After some bad news, let's go and do some up news. So scenario, there's another patient I've just seen recently. She had DCDA twins at 7 weeks, 35 years of age. She had a NIPS at 11 weeks. So what's our differential diagnosis? DCDA twins, one twin's trisomy 21, DCDA twin, both twins trisomy 21, DCDA twins fetal demise of one twin, or at false positive, neither have trisomy 21, or E, any of the above. So who would like to choose A? Who would like to choose B? Who would like to choose C? You want to put a hand up if you want to choose one of these answers? Or say D? Yeah, what are your options? What's your differential diagnosis here? E. All right, so what are we going to do next? We're going to refer for an ultrasound, any features of trisomy 21. And then what we found is that she had DCDA twins, demise of one twin with an 8-week size. Was this optimal management? Or not? I didn't think so, because she, was some weeks between the scan and the NIPS. Yes?
Is the demise between the one with trisomy 21 or the...
We don't know. We don't know. So she's now at 12 weeks. She's got this result. She's had a structural scan and no fetal abnormalities. So what is our differential diagnosis? And these are your choices. So both twins have got had the trisomy 21, and the alive one also has trisomy 21. That's a possibility. Yes, the dead one had trisomy 21, and the alive one had no trisomy 21, or actually neither twin had trisomy 21 and was actually a false positive result. So the counselling is a bit complicated. So I guess my question for you, if you want to raise your hands, what are we going to do about this? So your options are recommend amniocentesis, recommend CVS. Do you want somebody wants CVS? Hands up for an amnio. Some amnios, good. And some CVSs. Yep. Or a structural ultrasound at 16 and 20 weeks and then decide about the amnio. My view would be actually better to come for an amnio, because when you're doing the test, if you did a CVS, it could be difficult to determine whose placenta you're actually sampling. So really with an amnio, you can go in the sac of the fetus that's alive and you can actually do the test on that. But our patient decided that she didn't want to do anything further. She came for an amnio, the scan looked normal, and she said, look, I'm not going to do anything with these results anyway. She had a major anxiety disorder, and she decided she'd actually like to go and have a morphology scan locally in Wollongong, and then she would get back to us if there was a problem with the scan. But, you know, all of these things are possible. I think it's most likely that the demise twin had the trisomy 21, but then... you know, she just felt after counselling that was her preference. So we've got another patient who's got a NIPS result, trisomy 13. She's young at 24, we're young around here, and she's 12 weeks. So the differential diagnosis, I think, is either trisomy 13, a false positive result, or because we know the positive predictive value is the test is 25% in the low-risk women. So what are you going to tell her? So option A, you could say, just tell her to terminate the pregnancy because it's trisomy 13. No. Refer her for a tertiary ultrasound and a CVS. Hands up. 1 or 2, so it's the answer. Yep. Refer for a tertiary ultrasound, genetic counselling, plus or minus CVS, and oh, thank goodness. Love your work. Refer for amniocentesis. Good, or other. Oh yeah, I agree. C. All right, here she is. Staying woman, trisomy 13, 12 weeks, 24 years. Structural scan, no abnormality. I think we've done this. We have referred for a tertiary ultrasound, genetic counselling, plus or minus CVS. And with a normal scan, actually, it's more likely to be a false positive result. And then we refer her for an amnio. So if it looks like trisomy 13, we'd do a CVS. And if it looked normal, we would then discuss an amnio, because you can get false positive results, placental mosaicism. Now, this poor, lovely patient lives far away in a regional area, and she got sent for NIPS. So a whole genome NIPS, so they got sent it down to Melbourne. This is what they do where she comes from. And she got a BMI of 35, and she had an ultrasound at 10 weeks, and she had her first NIPS that failed. So how are we feeling? So what's our differential diagnosis or a plan? So could this be normal? Early gestation, high BMI, recommend repeat the NIPS. Yep, got some takers for that, yep. Could be normal, recommend first trimester screening. No takers? Oh yeah, we've got a taker, yep. Refer for genetic counselling, likely to be abnormal chromosomes. No takers. Means she's high risk for aneuploidy, refer for a CVS. Could be normal or abnormal, repeat the NIPS and perform first trimester screening. Yep, all right, good. High BMI, low gestational age, abnormal chromosomes, all associated with a failed NIPS. Choose option E in case it fails again. However, this poor patient, the second NIPS found multiple changes in multiple chromosomes, query an underlying maternal malignancy. And she couldn't actually access first trimester screening due to her rural location, and she got referred to us just before Christmas. Actually, when we had a bit of a chat to her, she'd had cough for 6 months. She had weight loss, she had a bit of a rash. And so we did a full workup for her in terms of clinical examination, bloods, ultrasounds of everything, chest x-ray, PET scan, and the very smart resident found a lymph node, a supraclavicular lymph node, and they were diagnosed that she had a lymphoma. And so after multidisciplinary discussion about her options and treatment, she actually said, look, this was an unintended pregnancy. I was really planning to change my contraception. I wasn't really planning to have a baby. I was actually wanting to see if I was fertile to do egg donation for my sister. We live in a rural area. We've got 2 healthy children and I want to stop the pregnancy. So that's what she did. And then she's had her treatment and she's in remission. But occasionally... this is a classic result with a cancer. You can sometimes get these results where they're uninterpretable because of cancer. So that if you get one of these, you might get one of these. Don't happen very often, but particularly if you're doing whole genome chromosome testing, that you can sometimes get a result. You think, I don't know what to do with this. So refer for genetic counselling and we will work it up. So I guess in terms of first trimester screening, preeclampsia screening. At the moment, New South Wales Health is doing risk factor based screening in terms of age, previous history. This is all part of the Safer Baby Bundle. If women who have got risk factors are being told to start on aspirin. However, you can actually do first trimester screening. The data suggests in retrospective studies and prospective studies that if you screen women and treat them with aspirin, you will reduce the risk. However, we need implementation in the Australian setting, as many services are not designed for this. There are a number of services. I know RPA is up at John Hunter in Newcastle. They completely redesigned their maternity services where women are all being screened for structural abnormalities and preeclampsia screening at 12 to 14 weeks. And then their antenatal care is redesigned around their risk. And I think that's a very interesting way that we should be looking at things. But we need to be looking at how do we do this in implementation, because it does add time and does add, cost to it. Anyway, I'm running out of time for this and I need to get Sarah to talk. So make a referral to maternal fetal medicine, call the fetus phone. Our midwives will coordinate your appointments. That's the number you need, 9 to 4:30. If you want to talk to one of us doctors, there's usually somebody around, but Marion and Tammy are very knowledgeable, will often be able to answer your questions themselves. So send all the information to us. And we also have a genetic service, so they're parallel. We live in the same department. We talk all the time. So we have genetic counsellors and geneticists as well. And so if you've got screening results, chromosomal or genetic condition history, family history, thalassemia, consanguinity, teratogens, and fetal abnormalities, all in the combined MFM genetics kind of thing. So questions at the end, or here we go, Sarah. She's disappeared. So we've joined this Preterm Birth Collaboration. It's a national collaboration and Sarah's going to tell you all about it.
Hi everyone, I'm Sarah Lyons, one of the obstetricians at the Royal Hospital for Women. Thanks for coming along today. I run the Preterm Birth Prevention Clinic as one of my many hats that I have here. And we know that preterm birth is an extremely important problem, both for the mother in terms of increased risk of obstetric intervention, being separated from her child that gets admitted to the neonatal intensive care unit. Also has significant implications for a newborn child. It has increased risk of death, cerebral hemorrhage, increased chance of requiring respiratory support, bowel necrosis and sepsis. And of course, these problems are more significant the earlier the gestation that the child is born. For children that are born at preterm birth, the impacts can be lifelong. So there are increased association with cerebral palsy, chronic lung disease, deafness, blindness, learning difficulties and behavioural problems. These problems can extend into medical complications of adulthood, including metabolic syndrome, increased risk of diabetes and heart disease, as well as concerns about loss of employment and socialisation issues. We know that behavioural and learning problems can be significant. So this just, if you imagine, have a centre where every child is delivered electively at 37 weeks gestation. So we know that early term birth is can increase this as well, these behavioural and special education problems. So if 500 children saw one obstetrician, or 500 mums saw one obstetrician, and all children were delivered electively at 37 weeks gestation, we would prevent one stillbirth. So there would be one extra child at school, but across every 3 classes, there would be an additional 2 children with a basic numeracy problem, as well as other special education or behavioural disorders, as you can see in the graph, in the image here. Preterm birth is also expensive lifelong for a child. So the cost, study done by Professor John Newnham in 2020, published in 2021, showed that the health and educational costs of preterm birth to the age of 18 years in Australia, overall it costs the government $1.4 billion a year. Most of this cost comes from the high expenses from newborn healthcare and the neonatal intensive care unit, but also additional educational costs through the child's life, particularly for early intervention. And the average cost overall for an extremely preterm infant is over $200,000. Preterm birth rates across Australia are increasing. So we can see the blue line is New South Wales, and since the early 90s has risen from just above 6% to almost 8% of all births in Australia. It's rising in all territories. We can see the brown line at the top is the Northern Territory with a higher Indigenous population. The rates of preterm birth have been upwards of 10%. So the National Preterm Birth Collaborative is a collaborative funded by the Australian government. It originally came from Western Australia, where they did a statewide initiative to lower the rates of preterm birth across Western Australia. So there are over 50 hospitals around the country that are working together to help reduce rates of preterm birth across Australia. The aim is to reduce rates of preterm birth by 20% by 2024. We've had a number of meetings which have been attended by our whole team, which I'll talk to you about our team in a moment. We had our first meeting in October last year. We presented us some initial data. We learnt about new data sources and learnt about quality improvement studies and use of audit tools, and developed our team. So our team consists of, as I said, to reduce the rate of early term and preterm birth by 20% by March 2024. As I had said, preterm birth, so birth less than 37 weeks gestation, is extremely important, but also trying to reduce the rates of early term birth because of particularly brain development and behavioural and learning problems. So this is our team. Our executive sponsor is our general manager at the Royal Hospital for Women, Donna Garland, and our team leader is Dr. Antonia Shand, who you've just heard from, and a number of clinical champions, including Dr. Bissett's, myself, Marion Jones, who works in maternal fetal medicine, Robin Gasparotto, who's our clinical co-director for maternity, Fiona Donovan, who many of you would know, who runs our antenatal clinic, and data collection support from Virginia Spear. As part of our collaborative, we've worked to establish our preterm, to add to some continuity of care to our preterm birth clinic, and Vicky Gay, who many of you may have met outside, has joined me in our preterm birth clinic, which is a wonderful addition to help be able to provide continuity of care and also a point of contact every day for our patients. So we started our preterm birth clinic initially specifically in 2020. Before this, patients were being seen through the high-risk model obstetric clinics. We aim to provide evidence-based management for the prevention of preterm birth. There are many clinical business rules. I don't know if any of you have seen our website, but things pertaining to timing of birth, use of progesterone, for example. And overall, our rates of preterm birth are reasonably low, which we'll come to at the Royal Hospital for Women, particularly compared to other level 6 maternity facilities across the state. We've got lots of work to do. We're trying to reduce our early term birth, which can be challenging. There are obviously many medical reasons for requiring birth before 39 weeks gestation, but our aim is to prolong pregnancy until at least 39 weeks where possible. We're aiming to have universal quality cervical length screening accessible to our patients and have contacted some radiology practices in the area, as well as giving advice about appropriate management for women with a short cervix. We really have problem with difficulty accessing continuity of care models within the hospital for many women, and we know that continuity of care can reduce preterm birth. And until the collaborative was established, we didn't really have a specific target in terms of what we were aiming to reduce our numbers by. We recommend that all women have cervical length measured at their mid-trimester ultrasound, and this can be done either transabdominally, as in the top picture, or transvaginally. We recommend women should have a transvaginal ultrasound if they have a history of preterm birth or premature rupture of membranes less than 37 weeks gestation. If their transabdominal ultrasound cervical length is less than 35 millimeters, we recommend a transvaginal ultrasound length. As you can see in the top image here, the cervix is quite stretched by that bladder. If you are unable to measure the cervix transabdominally, then we recommend transvaginal ultrasound assessment. Overall, the initiative from Western Australia did argue that actually all women should have transvaginal cervical length as part of their morphology ultrasound, but obviously that takes time and there are significant resource constraints, as well as it being an invasive part of the test for women. I'd ask all of you, please, if you are writing morphology scans, and many of these are being requested by you in the community, to specifically write if you would like a transvaginal ultrasound length based on the risk factors. And through our preterm birth clinic, we provide women that we're seeing through our clinic with a letter, as well as making sure that it's written so that it hopefully gets performed. This is the letter that we sent out to radiology practices. I won't read it to you, but it should have been provided in the packs that you received today to remind them about the importance of cervical length monitoring at morphology scan, as well as transvaginal length, and then providing a plan, which I'll come to, about women that do have a short cervix at morphology. So what do we do? If you get a report for a woman that has a transvaginal ultrasound length of 25 millimeters, please refer them to the hospital on the same day, ideally to the delivery suite so they can be reviewed by the obstetric team. We've also asked radiology practices, if they do find that a woman has a transvaginal cervical length of less than 25 millimeters, that they refer them directly to hospital rather than sending them to you to then come to the hospital. If this transvaginal cervical length is less than 25 millimeters between 16 and 24 weeks gestation, we can recommend commencement of vaginal progesterone pessaries, 200 milligrams at night, until 36 weeks gestation. This is an authority script and is on the PBS now for women. And then we would arrange follow-up in the preterm birth clinic in 1 week's time. We run the preterm birth clinic every Monday morning at the moment. There's a range, obviously, for cervical length is very short, so 10 millimeters or less on transvaginal imaging. We would consider it a cervical cerclage, vaginal progesterone, or a combination of those two treatments. PBS since July 2021 has progesterone on the PBS, so for women with a short cervix, so 25 millimeters or less on the mid-trimester ultrasound, and or a history of spontaneous preterm birth. So the preterm birth clinic, as I said, runs on a Monday morning. This is Vicky and I doing other things besides seeing women with short cervixes. The preterm birth clinic, would love to see any of the patients with the following. So any woman who's had a previous preterm birth at less than 34 weeks of gestation, or previous pre-labor ruptured membranes of less than 34 weeks gestation. Any woman who's had a second trimester loss between 16 and 24 weeks of pregnancy, if they've had a cerclage placed in a previous pregnancy, if they have a short cervix on ultrasound, if they've had 2 or more LETS procedures or any cone biopsy procedure, as well as any woman who's got a congenital uterine anomaly such as a unicornuate uterus. You would refer them to the antenatal clinic through the usual means and they will get triaged. You can also contact Vicky on the mobile number or via email. That information is also in the packs you were given today. Monday to Friday, Vicky will respond to those calls or emails to get the women booked in. As part of the questions that are asked on the online booking form, we also ask women about these questions, particularly for birth less than 34 weeks. So what do? We review their history. We try and ascertain the cause of their preterm birth previously and any previous treatments that they've been on, whether they smoke and any other risk factors for preterm birth. We know that smoking is an independent risk factor for preterm birth. We review their booking investigations, including a midstream urine, any ultrasounds that they've had to date. And then management really depends on what we think their cause for preterm birth was last time and their overall risk of recurrence. For women who had the previous preterm birth, we would do serial cervical surveillance, usually 16, 19 and 22 weeks of pregnancy. If they do have a short cervix, we increase the frequency of that surveillance to every 1 to 2 weeks, depending on their gestation and how short the cervix is. We discuss the role of cerclage, so elective for some women or in the setting, for example, of a previous rescue cervical cerclage or an emergency or rescue cerclage if the cervix is either less than 10 millimetres short or significantly shortening whilst on progesterone. We use progesterone primarily for women who have a short cervix, and there's been a number of recent meta-analyses that have demonstrated that this is where it's best utilised rather than history-based progesterone. Depending on how that time goes, we see them quite intensively between 16 and 24 weeks of gestation. Sometimes we return them to a low-risk model of care, but often we keep these women seeing myself and Vicky throughout the pregnancy in a continuity of care model through the preterm birth clinic. With the preterm birth continuity of care model functions very much like the MAPS model of midwifery care, so antenatal and some postnatal support. However, a number of women already have access to midwifery group practice, and they return to that model of care or to their medical model of care within the hospital. And we also aim to follow women who have had a preterm birth postnatally to ensure that they have help that with their improved outcomes in future pregnancy. So any woman who's had a preterm birth at the Royal less than 30 weeks gestation, we aim to see them in the clinic 4 to 6 weeks postnatally to have a debrief in regards to what happened for their preterm birth, look at any risk factors that might be modifiable and discuss to them what we would recommend for a future pregnancy. As part of the collaborative, we've been collecting data to see how we're doing. The green line is the Royal Hospital for Women and the yellow line at the top is other maternity level 6 centres in New South Wales. This graph looks at all preterm births between 24 and 36 weeks gestation for singletons, month to month since January last year. You can see on the left side of the slide, our preterm birth rate was less than the state maternity level 6 average, just over 6%. And it has bounced around a little bit, but we haven't seen any significant improvement in our preterm birth rate in the last 12 months. The other thing, as I said, we're very interested in is trying to prevent early term birth. Again, our rate was lower than other maternity level 6 hospitals across the state. We did see a significant improvement in October after we had our collaborative meeting in Sydney, where we had 4 months of significant improvement. The last few months have seen a return to somewhere along our baseline. So we're doing some audits at the moment, looking at reasons for induction, any caesareans that are performed before 39 weeks of pregnancy and aiming to try and reduce these numbers. We need to balance our aim to reduce preterm and early term birth against the number of babies that are admitted to the NICU or the special care nursery, as well as looking at our stillbirth risk to ensure that these numbers haven't changed. We can see that for our NICU and special care nursery admissions for babies greater than 39 weeks gestation do bounce around, but on average, looking at about 12%. And the other thing we need to look at is our stillbirth for all singleton pregnancies greater than 28 weeks gestation. We don't want to prolong pregnancy at the risk of increasing the chance of stillbirth. We can see there's been no change, and our numbers do bounce around a lot. This includes terminations of pregnancy for example, significant fetal anomalies. As part of the collaborative, we've looked at looking at agreed indications for planned birth at less than 39 weeks gestation and developing a checklist for all women who are having planned birth. And obviously, sometimes birth is indicated. For example, preeclampsia is something we see fairly commonly that requires delivery less than 39 weeks. We're looking at both caesarean section and induction of labour. As Professor Bissett's alluded to at the beginning of his talk, our induction rates are on the rise. We have increased our oversight of overall booking indications for induction of labour and review these on a daily basis. We're trying to incorporate other guidelines that already exist and looking at revising some of these. For example, there's a new cholestasis guideline that will be coming out shortly and a new New South Wales Health intrauterine growth restriction guideline. If there is a non-approved indication, there's further discussion at a consultant level from the both midwifery and medical teams to ascertain whether birth is indicated or should be delayed. We also look at ways that we're engaging with consumers and providing them with education, because often women, especially after they've had a preterm birth, feel or being transferred from other regional centres, can be quite isolated, and also considering about talking to women about why it's important to wait until after 39 weeks of pregnancy. And there are a number of ways that patients can access information. There's leaflets that go in their booking packs. It's important we speak to the patients at each visit, and there are posters around the hospital. So why is it important? Again, this information is in your packs that you were given today. Every week counts at the end of pregnancy. We know that there's ongoing brain development which continues until after 39 weeks gestation, and ongoing brain development has important implications in terms of learning and learning difficulties. We know that babies that are born late at term after 39 weeks gestation are much less likely to need specialised care in the nursery for breathing and feeding difficulties, and also less risk of learning difficulties at school. We know that this needs to be balanced against the rate of stillbirth. The rate of stillbirth at term is 7 per 10,000 pregnancies, whereas at 35 weeks is lower. It's important to remember every pregnancy is unique. There's no one-size-fits-all rule for management of timing of birth for patients, but we are really trying to think about medical indications for early term particularly. I've got a couple of scenarios. We'll do the same as last time. So we've got a woman who's, we're running out of time. I'll be quick. I'm talking as quickly as I can. So the first patient scenario is a woman who's had a previous preterm birth at 24 weeks. She's a smoker and she's had a previous LETS procedure. So how would you manage her pregnancy? You can A, refer her to the preterm birth clinic at 16 weeks. B, recommend a cervical cerclage at 12 weeks. C, recommend commencing progesterone at 12 weeks of pregnancy. Recommend smoking cessation and refer to preterm birth clinic at 12 weeks, or organise bacterial vaginosis screening and recommend transvaginal ultrasound at 12 to 14 weeks gestation. So who would do A? Any takers for A? B? No takers. C? D? Yeah, excellent. Or E, yeah. So I would recommend D, so recommend smoking cessation and we'd love to see her for around 12 weeks of pregnancy. We'll be talking to her about serial cervical lengths usually, plus or minus a cerclage. So what do we do? So normally we wouldn't do a cerclage at 12 weeks gestation unless there's been a nice trial that shows no benefit, but if there's any cervical shortening, then we may consider this. There's limited benefit in utilising progesterone history-based. Some guidelines do recommend it from 16 weeks of pregnancy. Absolutely want her to stop smoking. And in terms of transvaginal ultrasound, it's not very helpful until after 16 weeks of pregnancy. And bacterial vaginosis screening, it's controversial whether there's any benefit to doing this. Scenario 2, low-risk woman, routine morphology scan. Her transabdominal cervical length is 30 millimetres. What do you recommend? TV ultrasound, progesterone, cerclage, do nothing, or refer her to delivery suite. What would A, B, C, D, or E? Let's go with A. So because it's less than 35 millimetres transabdominally, would recommend that she has a transvaginal ultrasound performed. Can be a difference of up to 1 centimetre with transabdominal to transvaginal. She's had her transvaginal ultrasound and now it's 24 millimetres. What would you recommend? Repeat in a week, commence progesterone, cerclage, do nothing, or refer to delivery suite. E, fantastic. E, they're all happy with that? Okay, last scenario. A woman who is in her first pregnancy had a very preterm birth infant delivered at 23 weeks pregnancy. In her second pregnancy, she had a rescue cerclage at 19 weeks for a short cervix and unfortunately lost the pregnancy at 20 weeks. She went into spontaneous labour. What should we do in the next pregnancy? So elective cerclage at 12 weeks when she conceives, cervical surveillance from 12 weeks, and refer for pre-pregnancy abdominal cerclage, or D, advise against another pregnancy. There's a trial published in 2020 that shows that transabdominal cerclage is the treatment of choice for women with a failed vaginal cerclage. It's really important that we see these women for pre-pregnancy counselling. So if you meet a woman who's got this kind of history, I'd love to see her in the clinic for pre-pregnancy counselling plus or minus referral. And we have access pathways to laparoscopic abdominal cerclage through our gynaecology service here at the Royal. So very happy to see these patients at any time. That's all. We might move on to Dr. Shand has a little bit more to talk about and then maybe some questions.
All right, I've got things. So I just want to tell you about this course that's been designed by GPs for GPs with some collaboration with some others about congenital infections, about CMV and syphilis. So I just want to let you know about it. If you're looking for more points, it's free. So I've got, you can just take a picture of that, or I've got some little posters up there if you want to look at that. But I think it's a really good course. I just wanted to, if you want to come up and talk to us later, we've got some research projects going on. You might hear about our iSearch study about sildenafil or Viagra versus placebo in labour for prevention of fetal distress. It's a big national trial. It's half done. We're well on the way to getting an answer about whether it improves outcomes. There's a C steroid, so steroids for women having an elective caesarean after 35 weeks. There's another one for women who are having a caesarean who've got diabetes. We've been doing a screening pilot for type 1 diabetes in newborns. That study has closed on Friday. So we've been screening a whole lot of neonates around the country to look at whether we can screen for the genes for make them high risk for type 1 diabetes. Ikra, who's our midwife up the back, is here. She's got a lot of information about her hyperemesis and these new business rules and the pathways that are changing, which are going to be great to improve outcomes for women who nausea and vomiting in pregnancy, and we're doing some research on that. And also I'm pushing the pre-babe study for weight loss for women who are pre-pregnancy, BMI greater than 25. So it's online recruiting. If you've got anyone who might be thinking about having another baby who's BMI of 25 or more, interested in the study, it's meal replacement versus health coaching. And these patients are so enthusiastic in the trial. They're very grateful, enthusiastic, loving it. And we're looking at pregnancy outcomes. So pre-babe, we're trying to get the message out there for women who are planning pregnancy. If you've got questions, you can come to our booth. Oh, that's, yep, sorry, we've run over time.
Thank you. Can you hear me? Yeah, thank you, Dr. Shannon, Dr. Lyons. Got a couple of minutes for questions.
All right, yep.
Sorry, 2 questions. With the cervical length measurements, should we be talking to all women before their 19-week scan and saying, like, encouraging them to get the transvaginal scan to check cervical length?
The transvaginal, if you've got any transvaginal, if they have any risk factors that I mentioned, but making sure that when you get a report that there is at least a cervical length that has been recorded transabdominally, and if it's less than 35 millimetres, then they should be referred back for a transvaginal assessment.
So the question was about should all women have a transvaginal cervical length? The answer is everyone should have a cervical length. If you don't have risk factors, transabdominal's okay. If it's greater than 35, if it's less than 35 or risk factors, do a transvaginal. Good question.
Unless I'm mistaken, I noticed in your talk that in one of your scenarios that in the first pregnancy, a woman had, I think, normal cervical length, and the second one, I don't know why we were testing it. I mean, I can't quite remember, but is the cervical length, does it change from pregnancy to pregnancy or not?
Yeah, so the question is, does cervical length change from pregnancy to pregnancy? But it changes because it's a dynamic moving part of the uterine organ, particularly if they've birthed before, but it can change due to factors related to that specific pregnancy. So infection, for example, bleeding in pregnancy. So every pregnancy is taken on its own merit.
Good question. Why does preterm birth happen and what can we do to prevent it? It's not straightforward, but yeah, some of it is mechanical, some of it's inflammation. So yeah, screen every woman, every pregnancy, but if you've got risk factors, do transvaginal and please refer because we will put them under more surveillance.
Is there any data on vaping versus smoking for preterm birth?
I think it's still, sorry, the question is there any data for vaping versus smoking for preterm birth risk? I think it's too soon to say that there's any data for vaping, but we think that vaping is at least as bad as smoking. So would encourage all patients to stop vaping in pregnancy as well as to stop smoking in pregnancy. And it's an important issue because it's becoming more and more common. You ask a patient if she smokes, she says no, and then you ask if she vapes and she says yes. So really important to stop vaping in vaping at all, but particularly in pregnancy for preterm birth risk.
Thank you. I've just got one online question regarding the concern with retinoids, and they are asking, they're presuming you're only concerned with oral and not topical retinoids.
Yeah, that's correct. Oral retinoids are the teratogenic risk. So you should be on highly effective contraception. So implant or intrauterine contraceptive device or 2 methods. So pill plus condoms. So you need to be on a very high active, I mean, it is totally teratogenic. Same with some of these other like methotrexate and things as well.
All right.
My understanding is the topical retinoids are not particularly teratogenic.
All right. Thank you very much, both of you. We've got a small gift as a token gesture of our appreciation of you coming to talk today. Thank you.
Thank you.
Okay, moving on. to our next speaker. We are running a little bit behind, so I think we're going to catch up in the break after this presentation, so the break will be a little bit shorter than planned. I would like to introduce our second speaker, Dr. Gary Williams. Dr. Gary Williams graduated from the University of Sydney, trained in paediatrics and intensive care in Australia, UK, Nigeria and Texas. Dr. Williams has been a paediatric intensivist at CICU at Randwick for the past 30 years.
Thanks. Hello, can you hear me all right with this microphone? Okay, thanks. So what do I do? Okay, thanks. Look, I'll press right along. I put this slide in to say I've really focused on mechanical trauma of the newborn here. So we're talking about bruising, bleeding, stretching, fracturing. They're the sort of things that we're talking on. And I also wanted to say, while this slide was up, this isn't about me trying to box any of my obstetric colleagues. This is really a recognition. I've left off hypoxic ischemic injury, which is really a big area, and I recognise that particularly late in labour, babies are at risk of hypoxic ischemic injury, and critical decisions have to be made. And those decisions are about route of delivery and the use of instruments, and that's what this talk's really about. So it's really trying to look at current data and then to just visit a few cases that are hopefully of interest to you. When I looked at this, the best data I could find was this paper, which was published in early 2022 from Canada, and it was a national Canada review over I think it was a 6-year period of 1.4 million births. And really what they did was looked at data focused on trauma in children who'd had either an attempted forceps or vacuum delivery, and looked at the incidence both in normal vaginal birth, forceps and vacuum delivery. And this is a big busy slide, and I'll come back to this a few times and we can look at different lines in the slide. But if we go at the top, this is really looking at live births, spontaneous delivery. You can see there's just under 1 million, forceps delivery, vacuum delivery, and it's looking at overall the figures are about these are per 1,000 when we look at the rate. So significant neonatal trauma in spontaneous delivery is about 2 per 1,000. And obviously, overall, this entity is 5 times higher in forceps and vacuum deliveries. I thought, and then we'll go through each of those lines as I come back through. The other graph as a non-obstetrician, the other graph that was in this paper that I thought was interesting was that, that they looked here at the 11 regions of Canada, and they looked at a rate. This is rate per 1,000 live births. The red dots are in spontaneous vaginal deliveries. And you can see that across the board, spontaneous vaginal deliveries, it's low and it's pretty steady. And they noted that. And they looked at the triangle, so that's vacuum delivery, and it's pretty similar. It's higher than the spontaneous, but it's pretty smooth across the board. And then they looked at the forceps deliveries, and there was much more variability depending on the region, and they just left that hanging with the sort of, I think, inference or implication that maybe practice is important in that particular determination. So finally, the table that they published, which I think was interesting, was this table where they looked at the rates that they determined from their current study, and they compared them with the rates that are published from, this is the Canadian Society of Obstetrics and Gynaecology, the Royal Society, and RANSCOG. And if you look at intracranial hemorrhage, so they got about 0.7 per 1,000 live births, forceps, and similar with vacuum. And the numbers were similar, really pretty much across the board, maybe marginally higher in the RANSCOG guideline or document that was referenced. Subgaleal hemorrhage, mainly Ventouse deliveries, and about 1 in 300, and that was across the board, maybe a bit less in the Canadian guideline that was the reference article. But the other thing that was important was, particularly thinking about RANSCOG, you know, there's no data, there's no really good data that tells us, you know, in our environment that's published and reliable about several of these classes of mechanical injury in babies. So intracranial hemorrhage, just to start, in spontaneous deliveries, we're talking about 3 per 100,000 babies as a rate. So pretty rare, really, but you know, significantly higher in forceps deliveries, and higher still in vacuum delivery. So about 1 per 1,000 in those classes of babies, intracranial hemorrhage. Now, just to get the simple things out of the way first, just to remember that inside the skull, you've got subarachnoid between the pia and the arachnoid mater, and then probably got the most important, which is subdural underneath the dura mater, and then we got extradurals. And outside the skull, you've got between the periosteum and the table of the skull, we've got cephalhematomas limited by the not crossing the suture lines, and then between the periosteum and the galeal aponeurosis, got the more troubling one, the subgaleal hematoma, and then there's caput, which is often just tissue edema. So again deal with simple things first. Cephalhematoma, very common, and characteristics are that it's localised, it doesn't cross the suture lines, and you can see on this ultrasound done in a baby at a month of age with a cephalhematoma that there's a bit of peripheral calcification already visible. Here on a CT, you can see peripheral calcification and a bit of septation in this cephalhematoma, and this is a great bone window 3D reconstruction of a cephalhematoma at a month, and you can just see the calcification occurring on the edge. So cephalhematomas, common, localised, don't cross suture lines, but worrying to families because their baby's head looks like it's got a great big lump on it, and sometimes they take 2 months to go away, but are essentially simple and benign. When we start talking more seriously about intracranial hemorrhage, this is the problem. The problem is the frequency with which intracranial hemorrhage is there in normal babies, in asymptomatic normal babies. And there's a bit in the literature about this now. So here's a paper published in 2004 from Sheffield when they did an MRI in the first 48 hours of life for no good reason in 110 asymptomatic term babies. And what they found in babies who had a normal vertex delivery was that 6% of them had a subdural. It was a little bit higher in babies that had a ventouse. It was 8%. And if people tried to do a ventouse and then had to use the forceps, it went up to just under 30%. There was only 4 forceps deliveries alone, and there were no subdurals found, but a small number. But really the fact that 6% of asymptomatic babies who had a normal vertex delivery in this study had a subdural evidence on an MRI in the first 48 hours of life. And here's two years later, coming from North Carolina, a similar study, 100 asymptomatic term babies whose parents agreed to having an MRI, and they found intracranial hemorrhage in these babies in about 1 in 4. When they looked at them in birth, route of delivery, in 65 vaginal deliveries, they found 26%. The subdurals are small and they're mostly posterior fossa, but they're definitely there. They didn't find any in this particular study in babies that were delivered by caesarean. And when they looked at it for evidence of trauma from instrumental use, they in fact found that in their study, they weren't more likely to have had assisted vaginal delivery or maternal lacerations. And there was no significant difference in duration of labour or duration of ruptured membranes. But, you know, here are normal asymptomatic babies with subdurals on MR. So it is significant. Now, if the baby's symptomatic, it's obviously more of a problem. And when you look in the literature, this is the best information I could find. Published 2019, it was from Wales, and it was their own little series together with a close look at the literature. So symptomatic babies who either had floppiness, didn't feed well, had a tense fontanelle, had something, a seizure, or had some change in their state that caused people to look at them, scan them and find a subdural, a symptomatic subdural. They found 4 over 10 years in their environment, and they looked in the literature and found 30 more. And what they said was that in the majority, in 2/3 of them, they could be managed by just being observed by the neurosurgeons. And the overall recovery, the full recovery was 80%. So good, symptomatic subdural, 80% full recovery. Particularly if the baby was able to be managed conservatively, it was 95% full recovery. But if the neurosurgeons had to do something, drain a subdural, deal with hydrocephalus, insert a shunt, then it wasn't quite as good. 60% full recovery, and there were half a dozen babies with ongoing neurological problems. So that gives you an idea of the gravity of the subdural. And so, you know, when you look at that, what about fractures? So fractures do occur in normal vaginal deliveries. The rate is low, and the rate in their data was 1 per 100,000. It's 70 times more frequent with a forceps, and it's about 25 times more frequent with a vacuum. And you know, here was a case that the fractures can be either linear or ping pong in the baby's skull. They definitely occur in non-instrumental delivery, as I said, and they're more complicated if they're as a result of an instrumental delivery, but still skull fractures in babies are overall benign. Here's an ultrasound of a term baby with a parietal fracture, and you can see on the accompanying CT that there's a fracture and angulation and depression of this fragment of the baby's skull here with an associated extradural. This was a 10-year study published in 2005 from France, from Paris, where they did a 10-year review of all newborn baby skull fractures. This was a neurosurgical group. And what they found was that they found 18 skull fractures referred to them in babies that had had a spontaneous delivery, and 50 who were associated with instrumental delivery. And you can see from this table that there was more associated lesions. There's more intracranial hemorrhage and more parenchymal lesions in the babies that had instrument-associated skull fractures. But still, in the 50 instrument-associated skull fractures in term babies, the long-term neurologic disability was only 4%. There were only 2 babies who had long-term problems. When they looked at the instruments used, they were mainly forceps that got implicated here. And although forceps and vacuum were used, forceps or vacuum or both were used on both babies, or there were no babies just delivered with vacuums that had a fracture, that a third of them ended up being delivered by caesarean section. So here's a baby we had recently, baby born, good APGARs, no resus, but a forceps delivery had to be done. And you can tell from the arterial pH that the baby had a problem. The baby needed to be delivered. The baby was sending the message to the obstetrician, get me out. And appropriately, the baby was born. There was a cephalhematoma, born with forceps assistance. There was a cephalhematoma, but the baby was, apart from that, seemed to be establishing feeds normally. But when the swelling got a bit less on day 4, people thought they could feel a step in the skull. And when a skull x-ray was done, this small non-displaced parietal skull fracture was seen, and other imaging didn't show any intracranial abnormality, and the baby progressed normally. So the message is, even in instrument-associated skull fractures in term babies, largely good result, and only 4% of the babies in that series had a long-term neurologic problem. I put this slide in just to sort of bait my obstetrician friends, because I found this paper from 1979 from a group in Virginia in the US who described 3 babies with depressed frontal skull fractures, and this is one of them here, where they delivered the baby, diagnosed the skull fracture, and then decided that they'd actually use the vacuum to elevate the fracture. And so they put the ventouse on the baby and described how long they left it on and the pressure they applied. And so if you're thinking of moving into neurosurgery, then there's maybe room. Subgaleal hemorrhage is a sinister entity, and in the Canadian data, 4 per 100,000 in normal deliveries, but really goes up to 1 per 100,000 in forceps, but 1 per 1,000 in forceps and 3 per 1,000, or 1 in 300 in vacuum-associated deliveries. So it's mainly a vacuum-associated injury where the vacuum's applied, the scalp is stretched, and the vessels in the subgaleal space are at risk of being traumatised, and then bleeding can occur into the subgaleal space. And so here's the subgaleal space underneath the galeal aponeurosis, above the periosteum. Those vessels are traumatised by the vacuum, and then the hemorrhage can occur. And potentially there's blood, a great deal of blood can accumulate here. So there's been 2 coronial inquiries in Australia and 3 term babies in the last 3 years, in the last 10 years, who've died of subgaleal hemorrhage. And people say that when you see a subgaleal, you'll never forget it, because it's like the scalp gets disconnected from its base, and it's like the scalp feels like a blanket. You can sort of shake the scalp from where it's sitting on the scalp. Here's a series published in 2019 from Israel. Over a 10-year period, 100,000 deliveries, of whom 8% had vacuum deliveries, and in amongst that 8%, 4% had 4% of that 8%. They were able to find a subgaleal hemorrhage. So now, and they had a definition, as you can see there, fluctuant scalp swelling crossing the suture line, and they did ultrasound confirmation. So they had a really high incidence, 10 times what we would expect our incidence to be after a vacuum delivery. But the large majority of them were small. Only 1 in 10 of theirs were what they would call severe. They looked at risk factors for the occurrence by looking at these 350 subgaleals and comparing it with 300 other babies who had a vacuum but didn't get a subgaleal. And the risk factors that fell out were position, fetal head station, meconium stained fluid, how many times the cap came off, and how long people spent doing the VAD, as well as the presence of caput and the duration of the second stage. I suppose this MRI just demonstrates the amount of blood that can accumulate in a subgaleal space. And so we look at the babies, and when we're concerned after a vacuum delivery, we routinely measure the head circumference every couple of hours, and depending on if the head circumference starts to expand, look very closely at the baby as to whether there's any hint of hemodynamic compromise, tachycardia, and be very proactive in moving such a baby into a higher dependency area. What about potentially for vascular access, cross-matching, and potentially transfusion if needed? Peripheral nerves. So this is really about stretching, and you can see overall normal vaginal deliveries, we're talking 1 per 1,000, but higher in forceps 5 per 1,000 and in vacuums 4 per 1,000. So, and this was an interesting little baby who was referred to me when I was doing a regional paediatrician locum in a country hospital, because another hospital nearby, obstetric staff delivered the baby and thought the baby might have had a stroke, didn't think it was moving correctly. And you can see here, you can see she's bright as a button. She's visually incredibly alert, and when I tickle her, she looks, she almost gives you eye contact. She flexes up her hips normally, her right arm's moving normally, but her left arm's going into classic waiter's tip. And she's alert. She almost starts to lick and suck, and she's really very reassuring. And so she's got a 5-6 brachial plexus stretch, and here are the nerve roots coming off the cervical spine, and the large majority of these, in fact, resolve spontaneously in the first 2 months. The large majority are a stretch, not a tear. And in her case, she had hand movement, finger movement, and she also had biceps flexion, and they're positive prognostic features, and that baby had improved significantly by, not completely, but had improved markedly by 6 weeks of age. And here's a baby, the investigation of choice if things aren't going well, if there's concern about more significant injuries, an MRI, and here's an axial scan of an MRI on such a baby. And you can see here a pseudomeningocele is here, that's a sign of injury, and this is disconnection of the anterior nerve root off the spinal cord, and that's a sinister sign. That's not going to get better. Whenever you get stretching injuries, the other things we have to look for or think about, sternomastoid tumour, so in the delivery of the head, stretching the sternomastoid, and this is something which will largely get better with physiotherapy and time. Here we've got a baby with a unilateral elevated hemidiaphragm due to a phrenic nerve palsy. Got to think about that. And here we've got, again, in stretching injuries, clavicle fracture, most commonly diagnosed at 6 weeks of age by people finding finding callus, rather than a newborn baby checker finding a fractured clavicle in a baby. But got to think about that in this situation. This is a fascinating case of a child who was referred to me for food allergy. And the message from this story is listen to the mother. And he came in, and the story was every time he ate, and there were a range of foods, after 2 minutes he got this local erythema over his cheek. And the interesting features were it was in a result of lots of different foods, initially stewed apple, but then carrots and broccoli and lots of other foods, and foods that he seemed to like. It definitely took 2 minutes to come on, and it was always unilateral. And I thought, what could this be? And I was scratching my head, and the mother said to me, do you think it could be Frey's syndrome? And I had to say, well, just hang on. And I got my phone out. Frey's syndrome is when she actually said to me, do you think it could be from the forceps delivery? And she was a very bright woman. She'd worked it out. She'd looked up unilateral facial flushing post-Apple on Google, and it's because there's a nerve here called the auriculotemporal nerve that's got parasympathetic fibres that are going to your parotid gland. And the forceps blade crushes the nerve, and then when the nerve grows again, it doesn't get to its correct destination. It innervates the skin, localised on this part of the cheek, and you get dilation. When you were going to salivate, you get dilation, and sometimes you get sweating. It gets better in children as they get to early childhood, but it often doesn't go completely away, and that's Frey's syndrome. Ocular injury is there's a range of potential ocular injuries from instrumental birth to children. And here was an Irish review published in, I think it was 2015, where they quoted 1 in 400 forceps deliveries, but there's a range of things that were found. The interesting thing from this review was, you know, retinal hemorrhages, if you look hard enough for them, will be found in 20% of babies who have an instrumental delivery. Those retinal hemorrhages should all be gone away completely by a month of age. And a lot of the injury that this review documented was things like bruised eyelids, hyphema, subconjunctival hemorrhage, common. But the most important injury to know about is corneal injury because of its implications for the child's vision. So if you look at the cornea here, there's a number of layers, and on the posterior layer, just adjacent to the anterior chamber, there's an endothelium, and then here there's a membrane called Descemet's membrane. And Descemet's membrane's really thick, and because it's really thick, it's not like your stocking, it doesn't stretch with you. And so when the forceps blade comes over, if it inadvertently compresses the orbit against the inferior orbital ridge, it applies pressure to the orbit, and Descemet membrane splits, usually vertically. And one of the things Descemet's membrane does is it keeps the cornea clear. It keeps the cornea from becoming edematous, the anterior chamber fluid getting into the cornea. So here's a child at a couple of weeks of age or a week of age with a torn Descemet's membrane and corneal edema. And here's the appearance of the eye at 6 weeks of age, where you get this localized haziness in the line of where Descemet's membrane has split and then scarred. And this has significant implications for the baby long term, potentially for amblyopia, for vision and amblyopia. And so that's really got to be looked for if somebody's done a forceps delivery and inadvertently the blade's gone across the eye. Nasal injury is obviously also a concern, but the literature in nasal injury is a bit murky. Septal deviation from the force of the forceps blades, not up 0.5%, but there's reasonable evidence of spontaneous correction if you apply a conservative approach, really. And here's a baby we had recently. The blade went across the nose. The baby got a deviated naval septum that you can see there. His nose is pushed to the side, but he fed well. He had clear airflow through his nostrils. A conservative approach was applied, and there he is at about 6 weeks with a straight nose with a conservative approach. But if a baby's got airway obstruction with respiratory symptoms, cyanotic episodes or stertor, if he's got feed interruption, because babies are obligatory nose breathers, then there is an argument that something might have to be done for a deviated naval septum. There is an entity called nasal subluxation, and this is rare, but it is an indication to intervene. Here's a baby from the literature. Had a traumatic delivery at 36 weeks, and you can see his entire nasal cartilage is shifted to the left as a result of the trauma. And this baby needed to be intubated at birth and then extubated at day 3 and re-intubated because he couldn't breathe. And to cut a long story short, he had MRIs which showed that there was complete subluxation of his nasal cartilage structures off the maxillary bone where it should have been, and this resulted in nasal airway obstruction, and he had to be intubated several times until the decision was made to do an operation and move his nasal cartilage structures back onto the right place and then hold it in place with a splint for a while. I hope I haven't gone too long. So my summary is mechanical neonatal trauma is rare, that virtually all forms of neonatal trauma do occur in non-assisted deliveries, but the incidence and severity of injuries increases when instruments are used. It's important that we know them, and important that we are updated on the best data available for their incidence and for how we can talk to parents if and when they occur. I suppose the things I learned out of reading to give this talk recently were things I've learned a lot today, actually, but the things I learned when I was reading for it was that intrapartum ultrasound to look at the fetal head station and the orientation of the fetal head is something that I didn't realise people do, but obviously I think there's an emerging literature. And the other thing I learned, which I wasn't aware of, is that the practicality of trainees gaining experience and expertise in instrumental delivery. In fact, I think there is evidence that that's increasingly difficult and increasingly problematic. And so that's where I'll leave it. And I'll be happy to answer any questions.
Thank you very much, Dr. Williams. I don't think we've yet had any questions come through online, so happy to answer some from the audience.
You've got to ask me a question, otherwise I'll think you haven't been listening. I always, you know, I can tell a joke, and I was thinking the joke I could tell you was that I actually think I had a traumatic delivery, you know, because my mother, I'm one of 9 children, and my mother remembered the intricate details of the delivery of every one of us, even when she was in her last years and she'd got Alzheimer's and didn't really actually know who I was. But if you asked her about Gary's birth, she could tell you the details of the birth. And she told the story, she used to tell it, you know, for years, that every time she had a baby, her maiden aunt would come into the room at St Margaret's at Darlinghurst, and with her gloved hands, she would look down at the baby and she would say, "What a beautiful baby." And then when I was born, my mother says she came into the room and she looked down and she said, "Oh my God, what happened to him?" So I think I must have had a... Sorry, there was a question.
Yes, the online question is cephal hematoma in newborns. Can we observe or should they have skull x-rays to get better information?
Cephal hematoma. No, I don't think a baby with a simple cephal hematoma should have anything beyond clinical assessment. I think that cephal hematoma is so common and so benign that if the baby is feeding normally, behaving normally otherwise, I don't think any further investigation is warranted. I think in those scans that I showed you, that baby had had a seizure, and so at a month of age, and then baby got CTs and MRs. But in a baby with a cephal hematoma, I don't think doing scans is justified. I think that's a benign entity and it will go away with time. The peripheral calcification and the cephal hematoma, if imaging is done and you see peripheral calcification, that's reassuring. That says the process of resolution is underway. And so but I wouldn't investigate a baby for a cephal hematoma at all.
Can I ask a question? At what stage is corneal damage, scratch noticeable? Because, you know, we usually see babies at 6 weeks. That can be very difficult actually to even get them to open their eyes. That's not difficult.
Yes. Yes, examining babies' eyes is really very difficult. I suppose what we're required to do before the baby leaves hospital is do an examination with an ophthalmoscope and get a red reflex. And really, it's very difficult for a baby on day 1 to do that. Babies don't open their eyes. You have to turn the lights out, make it dark, coo at the baby and sit the baby up and be friendly, and then the baby might open its eyes. The mother might say, "Oh, the baby's opening his eyes all night last night. He was looking at me, but he won't open his eyes for me." I'm much more successful at getting a baby's open their eyes using that technique when the baby's day 3 or 4 and lactation's established. But I think that I think that the most common thing parents find, and I find when I check a baby, is subconjunctival hematoma, and parents are often worried by that, but it's incredibly benign. I think that the only corneal injury I have to confess The only corneal injury that's happened to a baby of mine that I've been following, I found at 6 weeks when I looked at the baby, and the mother asked me what the shadow on the baby's eye was. And then I saw the vertical scar on the cornea. And so I didn't see corneal edema in the first few days of birth. But I think in any baby that has a forceps delivery, if the blade has gone across the eye, somebody able to look closely at the eyes at 6 weeks of age should examine the baby's eyes and have a low threshold for sending the baby to an ophthalmic surgeon, because a year later or 2 years later, if a baby's got a corneal scar, amblyopia can be well on the way to occurring, and one really needs to be careful to intervene at an early time.
All right, thank you very much, Dr. Williams. Welcome back, everybody. I would like to introduce our third and final speakers for the afternoon, Kelly Tytherleigh-Laity and Kimia Sharifi Nasab. Kelly Tytherleigh-Laity works as a physiotherapist at the Royal Hospital for Women. Kelly completed a Bachelor of Physiotherapy with honours at Monash University, graduating in 2020. Since graduating, Kelly has developed an interest in improving rural healthcare accessibility and outcomes, as well as working in women's, men's and pelvic health. During her time working at the Royal Hospital for Women, she has led and contributed to numerous maternal health services and quality improvement projects. Kimia Sharifi Nasab works as a senior physiotherapist at the Royal Hospital for Women. Kimia completed her Bachelor of Physiotherapy with honours at Australian Catholic University and is currently completing her Masters of Physiotherapy in Continence and Pelvic Health at Curtin University. Kimia has had experience working in women's health across a number of different hospitals in New South Wales, including Westmead and Wyong hospitals. Her passions lie in service delivery and reform through focus on the patient experience and journey.
Hi, everyone. My name's Kimia.
And I'm Kelly.
And we are very excited to be here today after what seems like a fair bit of time throughout COVID to interact and update you all on some of the really exciting service upgrades and additions that we've had to our physiotherapy team and service as part of the Royal Hospital for Women today. We are representing our team, and before we get started, we just want to say a very big thank you to Chantel and the GP advisors, Zoe, Marine, Anne and Liz, who have invited us to talk here today. Now, today's talk will look at exercise, pelvic floor exercise and pain, and we'll go through the streams and how our services tie in within those three main streams. We'll also, throughout the talk, I'm aware it's a half-day event, but I know it's a Saturday, and for some of you it may have been a big week.
So what we'll do throughout our talk is whenever there's a really, really, really important point that we want you to take away and start implementing tomorrow, we'll do a little bit of a call to action. So we get everyone to stand up, do a bit of a move around, because we're physios, so that's what we do. And then we'll tell you our call to action so you won't forget it, and we'll be able to do all these wonderful and fabulous things together. So to get started, our first stream that we're going to speak about is exercise. Now, exercise throughout the maternal journey plays a significant role in the prevention and management of many maternal health conditions and symptoms, as I'm sure you all already know. I just wanted to go to the first 2,000 days framework, which I'm sure is a strategic framework that you are all familiar with. And it outlines the importance of the first 2,000 days of a child's life, so from conception to the age of 5. The first 2,000 days of life is a critical time for physical, cognitive, social, and emotional health. And what happens in these first 2,000 days has been shown to have an impact throughout life. For example, just to name a few things, early life experiences are strongly predictive of how a child will learn in primary school, their school performance, their adolescent pregnancy rates, their connection with the criminal justice system, and then the development of chronic disease later in life. And so a lot of our services today don't only identify the postnatal journey, but more importantly, that antenatal journey, and from conception, what we can be doing to improve these maternal health outcomes throughout what is going to be that child's remainder of their life and that mother's remainder of their journey. Now, just as a starter, exercise is, as we all know, a really, really significant factor in preventing and also managing a lot of gestational disease. Just to rattle off a few, so these are some articles from 2006 as late as 2022. Prenatal exercise reduced the odds of cesarean section and did not increase the risk of adverse maternal or neonatal outcomes in mothers with pre-gestational medical conditions. And other articles showed that exercise-only interventions were effective at lowering the odds of developing GDM, gestational hypertension, and preeclampsia. And early to mild physical activity was effective in the prevention of GDM, just to rattle off a few. Now, associated maternal outcomes with exercise include the decreased risk of GDM, preeclampsia, macrosomia, depression, anxiety, pain, and urinary incontinence. And associated fetal outcomes with early exercise include decreased likelihood of instrumental delivery, increased APGARs, and benefits for placental health and growth. Now, exercise throughout the maternal journey is really important, but we really, really want to hone in on those first early days as well. And they're strong predictors of things like GDM and preeclampsia development.
Beautiful. Now, I think my microphone's working as well, but we will touch on this and do a call to action a little bit further along, but we just want to introduce one of our programs, which you may well all be familiar with, Embody Pregnancy. So this is the antenatal arm of our Embody program. It's a free virtual physio session that promotes better health outcomes for new and expecting mothers. And essentially what we do in this program is educate women, so empower women on the benefits of exercise. We empower them on safe completion of exercise and different forms and modes of exercise so that they feel confident completing this. We also actually spend 7 to 10 minutes of our half-hour session getting women up and doing an exercise session with them so that they can, you know, build that self-efficacy while they're attending the session as well. So I'm sure you're all familiar with the RANSCOG guidelines. They're on the screen up there. I won't repeat them. We really emphasise and try to make it achievable. So thinking moderate intensity exercise is an intensity at which you could talk but not sing. So a brisk walk to and from work. These women are often working. We run these programs at midday so that women, we understand that often pregnant women are working. We want to make it accessible so they can attend in their lunch breaks. In terms of the resistance, you know, if people go to the gym, they do CrossFit, then that's great empowering them to continue that with considerations for symptoms, pelvic floor function, etc. If, you know, certainly we recognise there's a proportion of maybe non-exercisers or new to exercises. So explaining to them that resistance can be something as simple as a 10-minute kind of HIIT workout at home, or, you know, with some full water bottles as weights or cans of beans, building that confidence with body weight exercise. And I think this is a nice question to, you know, ask our women, ask, you know, ourselves if we're confident in saying, is there a time that women should be stopping exercise? Has anyone got any thoughts on this? Do women ask you if they should be stopping exercise in third trimester? I can see a few nods there. Perfect, you're all over it. So I just had a comment saying exercising as long as you can, and that's right. It may not feel like it did when you weren't pregnant, and that's okay, but empowering women to exercise for as long as they can, and to expect what normally happens when we exercise. We get short of breath, our muscles get sore. That's okay, that's expected. We may get short of breath a little bit earlier because bub's taking up the space that our lungs usually have to expand. So making sure we build that confidence for women to continue with that, given all the benefits Kimia's just touched on.
Now, and I forgot to mention, if you have any questions, we will answer any of them at the end as well. Going on to exercise. So we've got our body program, which is made for everyone. It's meant to be a timely, accessible, available to all women that are birthing at the Royal Service. And it provides general recommendations. And if we feel, if any women need to have further review, then we do follow them up one-on-one. Following from that, we've got our gestational diabetes service. So there is already a service within the Royal. And just to refresh everyone's memory, GDM is known to affect 5 to 15% of pregnancies worldwide, and is managed as a high-risk pregnancy within the health service. GDM has well-recognised risk factors for developing the condition, including previous GDM, being overweight or obese, excessive weight gain during pregnancy, a family history of GDM or type 2 diabetes, high parity, and advanced maternal age. We know that exercise in the management and prevention space of GDM has shown to improve blood sugar levels, reduce excessive weight gain during the pregnancy, and have a potential for reducing the insulin intervention, or possibly decrease the amount of insulin they need to be on during the pregnancy. Now, just to give a bit of background, currently our GDM service within the Royal includes a team of diabetes educators, endocrinologists, and dietitians. And we're very excited to announce that since February of this year, physiotherapy has now joined the team. So Kel's going to explain a little bit about how we are integrating into this service.
Yeah, so essentially women have their glucose tolerance testing around that 20-week mark. Women who are found to have GDM get referred to their education session. And essentially in that session, physio are there to provide education on the benefits of exercise, what intensity women should be doing it at, because exercise is great, but in fact, to really help with blood glucose control, it needs to be quite high intensity. So really explaining and reiterating that to women and explaining the ways in which they can achieve that. And also the timing of the exercise. So that post-meal timing 20 minutes within an hour after finishing eating. So we're in that education class. There's also a QR code, which I believe you will get to that in a moment, which is in the packs, but the women can scan a QR code or do a link, complete a survey, and we actually run group classes in our physiotherapy gym here at the Royal. There's 8 different times throughout the week that women can attend, and essentially they're welcome to continue that for the remainder of their pregnancy, and we recommend coming as much as they possibly can. So those 8 sessions are spread over 3 days of the week. If they feel like they're building enough confidence and self-efficacy to then carry that out at home, that's also obviously encouraged. The other option with this is that we're providing virtual appointments for women who can't attend in person, but just to review what they're doing and different options that they can include at home. And I think this is where certainly Kimia, I'll hand it back over to Kimia, but essentially we're working with the women being diagnosed, but I think Kimia's touched on really nicely, we'd also like to work in the preventative medicine space. So actually helping women or reduce the risk of high risk women developing diabetes. And that's where we'd love your support and your help.
So our first call to action, everyone can stand up. You can roll your shoulders. You can do some pelvic floor squeezes, but no one should be able to tell that you're doing them. You can just walk on the spot, stretch your cells out, get the serotonin running. Feels good. Fabulous. And in your own time, feel free to sit back down. But our first, as Kel mentioned, is that we do need your help in this space. So at the moment, we are able to pick up the women once they have been diagnosed with gestational diabetes. And obviously, we can see the significant role that we can play for the management component. What we really want to try and do is get women at risk of gestational diabetes mellitus development. And so in your packs today, you'll find these little laminated cards. If you can take them into your clinic, pop them near your computer, near your desk, anywhere. The risk factors, I'll forget them every now and again. So they're listed there so that if anyone at the time of confirming a pregnancy or in the earlier part of that pregnancy, if you note that a patient might be at risk of development of gestational diabetes, you just get them to scan that QR code. What that will do is that we'll then get their responses and we'll be able to be in touch with them about any of our services if they may be interested. And the idea is that they don't have to come in every week to do exercise classes. It's tailored to the individual. So it depends on what works best for them. And if it means giving them a home program, then they can do that at home on their own. And yes, I can see a hand, but yeah. Take a photo. Oh, the QR code. We'll be able to send like the link for that survey it can be distributed through a newsletter or something. So if in case you lose that code, yeah, that's a very valid point.
Just repeat that for those online. The question was that if the card is lost, we are very happy to provide posters for clinic waiting rooms. We're very happy for you to have our emails and actually email us through the patient details. You can send a referral form if you haven't got the code. Any of those modes are fine. The code's obviously just very efficient because it goes straight to the physio being contact and organise what suits the woman best essentially. But yeah, don't fret. If you lose the QR code, just send through a referral.
Or what you can do is go to your clinic. The first thing you do is take a scan of it, put it on your computer, and then if you lose it, you've got it there, the soft copy forever. But yes, we will also always be more than happy to send those through.
Alrighty. So our second topic is pelvic floor exercise, and I think this overlaps really nicely with exercise, and maybe I've given a bit of a hint with this, but if there's any thoughts, again, I'll throw it back to you guys about when the best time to start pelvic floor exercises is. Is anyone sort of giving women education on this at this point? Is it as soon as they conceive? Is it, I can see a few nods there. Amazing, pre-pregnancy. So essentially we're working on that preventative approach with pelvic floor muscle disorders as well. And that's the evidence has shown that that's the most effective. So if we can get women to start pelvic floor training early to stop or prevent the development of pelvic floor disorders or conditions during pregnancy, that carryover happens throughout the remainder of their pregnancy and also is a predictor postpartum as well. So reiterating that to women so women understand why pelvic floor exercises, we're pelvic floor physios, but they're boring sometimes, particularly if you don't make them functional and exciting. So women can do that while they're exercising, while they're at the gym. Do it with movement. That's even more functional than, particularly not laying down doing squeezes, but making it exciting, making it functional. And I think this slide speaks to just moving back into why as well. So we know during pregnancy, obviously we have bub growing in our uterus, which brings with that a weight of the placenta, growing uterus, so increased uterine weight. We have more fluid volume in our body to make sure that fetus is getting adequate nutrition supply to grow. So we have all of these factors which are then putting excessive load or added load through our pelvic floor, which is why it's very common, and I'm sure you're all very well aware of this, in that often pregnant women do develop pelvic floor muscle symptoms in their pregnancy. So just reiterating that to women, and you can see on the right side of that, it's the right side of your screen as well, some of the other associations with pelvic floor muscle training in pregnancy. So prevention of pelvic floor symptoms, improved birth experience, because the women know when they're squeezing pelvic floor and when they're relaxing pelvic floor. So they actually are empowered during that labour if they're having a vaginal birth, as well as it's also the first line management for any urinary incontinence or anal incontinence. And I think this is another nice, thought that we often get, particularly in our Embody program, in that I don't know if any of you have had women ask you this should I stop strengthening? Should I stop doing my pelvic floor strengthening in 3rd trimester? And I might just get maybe a show of hands, because we'll have you guys sitting and standing enough, but a show of hands of anyone who agrees with this statement. Should women stop strengthening their pelvic floor in their 3rd trimester? No, amazing. So there's no hands up in here, and absolutely. And I think we've touched on that, because the stronger the woman goes in, like a knee surgery, the better the outcome. It also improves their awareness of their pelvic floor function.
Which brings us to our next point, and we won't spend long on this, but we just wanted to address the lady or the woman that comes in and goes, oh, but my pelvic floor is too tight. I can't have a vaginal delivery. I've been told by my physio, I've been told by another health professional that I just cannot. I think this is a really tricky area to maneuver. We have to make sure that we're empowering women and ensuring that they have the right information, but giving that information in a really sensitive way. What we have to say about that is, I guess, if you have ladies that present to you that are saying those things and you would like a second opinion, or you would like them to be informed or made aware of maybe just more their pelvic floor function. So we are not here to tell them to have a vaginal delivery or a C-section. That is not our role. But what we are here to do is to give them the knowledge and the information to be able to better understand their bodies and the birthing experience. We do have a service which ties in really nicely to a little bit about the mode of delivery or mode of birth considerations, which we'll touch base on towards the end of the presentation today. But again, an embody attendance is the first and foremost point of call. They get all the information about their pelvic floor function, and towards the later stages, they get started on a little bit more around the relaxation focus along with that strengthening.
Beautiful. So this brings us back to our Embody Pregnancy program again, which we introduced. And you can see on the screen there the topics explored. So we look at educating women on the role and function of the pelvic floor, and we actually set them up with their own individualised program in those sessions and progress that at the subsequent sessions they attend, or modify that. Women can engage and ask questions throughout, so we can give that live real-time feedback as we go and modify it to the women attending on that particular day. We cover exercise, as I touched on, urinary and bowel incontinence and symptoms. We talk about birth prep and empowering birth prep and considerations there, as well as musculoskeletal pain. Now you can see, I think this diagram illustrates really nicely that load on the pelvic floor. This is the strength as per a normal strength programming principle. So we do 70% of 1 rep max, which is a max contraction for how long they can hold that for. You can see reps. We make sure women are relaxing, so really emphasising that full range of movement, so that we're, as well as strengthening the pelvic floor, making sure women know how to completely relax. As I touched on earlier, we talk about that functional use of the pelvic floor, so particularly what's known as the NAC, so squeezing the pelvic floor when we do lift up something heavy, if they have toddlers or if they're coughing, sneezing, stress urinary incontinence. I'm sure you're all very well aware of is that common presentation. So using the pelvic floor functionally in those sort of intra-abdominal pressure changes, as well as providing progressions. So with that note, another call to action. So everyone stand up, move around, maybe a pelvic floor squeeze as you do a squat this time if you feel like it. And just while you're all standing, we'll do the call to action. And essentially with Embody, you can see we run the 4 programs, the timeframes on your screen. we would love it if you can just help us to educate and inform women about the program. When they register to birth at the Royal, there's a tick box that says yes to physio. If the women say yes to that, they'll get a text message. So we go through all those registrations and enrol them. All they have to know is that it exists, and they'll receive to say yes on their registration form, and they'll receive a text message the day before their session, which they can just hit the link and log in. And I think Kimia touched really nicely in that if you've got a woman who's only having mild symptoms, or they're not bothered, or they just want some more information, the first port of call is Embody, because we actually have a survey in that text message where they can self-refer. So we go through a range of the different symptoms, and then they run through their bother, and that will automatically trigger a referral, which we will then contact them and reach out to organise an appointment in the appropriate clinic. So, you know, taking that power back to women, that if they have concerns, it doesn't have to just be from you guys, but actually Embody's a really nice pathway to seeing us one-to-one if they need to. But often, and ideally, a lot of symptoms can be prevented and or managed, mild symptoms in Embody as well. So just to reiterate, educating, yes on the registration form, and that they'll get a text message would be amazing. Thank you. Awesome. Yes, a question up the back. Yeah, so the question was just if they hadn't already been attending Embody, they have mild symptoms and they want to attend Embody to address those. You guys can send through a referral, because that is a little bit tricky, and that's a really great question. They can reach out to us just by calling the department or emailing, and we can just enrol them. Otherwise, you can just send through a referral normally and just say for Embody. Yeah.
And actually on that, we have another service coming up, which will probably answer that a bit better, but we'll leave it for later.
Yeah. But great question. Thank you. So our third sort of topic and theme for today's presentation is pain. And certainly, again, another common statement from women, and maybe something that women commonly hear from healthcare professionals, is that pain in pregnancy will not improve until after delivery. Just a nod if anyone's heard that before. If women have, you know, I've got this back pain or this hip pain, but, you know, it's really impacting me, but it's absolutely not going to go away until I have the baby. And, you know, we certainly say that a lot. Oh, sorry, women certainly say that a lot to us. Sometimes, you know, it's an impact on women's back and pelvis and the way their muscles, you know, are functioning, and the length and tension relationships of how their muscles can contract and that neuromuscular control. But it's actually, I think, really important to consider the impacts of pain on the women or the woman during their pregnancy, and as well as their journey in the postpartum period, and that we actually really should be fixing that pain in pregnancy. The reason for that is that you can see here, so birth trauma, so 1 in 3 women will experience birth trauma, and 2 really strong predictors of birth trauma are pain. So obviously that lumbo-pelvic type pain. You can also have rib pain, hand pain, hip pain, etc., as well as powerlessness. And if we can't help women to improve that pain, then that's going to leave them feeling like they, you know, hopeless, powerless, that there's not options there for them. So really trying to get on top of that as soon as we possibly can. Obviously, the earlier we start to, you know, implement strategies to fix the pain, the easier it will be, rather than leaving it until the pain's quite debilitating. Now, another thing to consider about pain is its impact on exercise and women's desire to engage in exercise. I don't know about you all, but if I've got a sore knee or a hip, I'm not going to want to go for a run. It's, you know, it's just going to hurt. It's going to make it worse. So we want to make sure that we're improving the pain to allow women to exercise, because we know the benefits of exercise in pregnancy, both for the woman and for bub. And that's where I guess, you know, Embody's a really nice protocol, as well as you guys and physio generally, just in terms of doing some motivational interviewing, providing strategies, and improving their knowledge of what's safe and what's recommended, as well as postnatal depression. So there is studies to show that women with lumbopelvic pain are 3 times more likely to have postpartum depressive symptoms. So again, trying to get on top of that pain before the woman actually goes into labour and delivers. Now, given, I think that's the pregnancy component of pain. Now, we know low back pain is a high burden on the health system in the general population as well. So it's got a high cost, a very high prevalence, and has a significant impact on the people who do experience low back pain in the general population. With that in mind, there have been a number of leading bodies that have contributed to this guideline created by the Australian Commission on Safety and Quality in Healthcare. It's in our reference list, it's online. If you haven't seen it before, it's super helpful. And certainly is really nice applied to the physio population as well. So you can see the 8 key points there, initial clinical assessment. And I just want to highlight with this, you know, obviously this is a really nice one. If the woman sitting in front, you know, in an appointment with you all, then ruling out, is there any signs of specific or serious pathology? And the guideline recommends using this terminology rather than previously used red flags. And that's because varying combinations of symptoms are with different pathology. So if you think of a cauda equina presentation versus a cancer presentation, they'll probably be quite different in terms of what the woman's reporting to you. Versus something like a vertebral fracture. So ruling that out, and then you can flick through a referral to us straight away, and we'd be very happy to see that woman within a very timely manner. And we'll get to that type of referral. You can see point 2, psychosocial assessment. So looking at factors that might limit a woman's or restrict a woman's ability to improve from a psychosocial perspective. Reserving imaging only for suspected serious pathology, and just noting the poor correlation between findings on imaging and symptoms. So studies have looked into imaging in asymptomatic populations, and there's plenty of findings on those spinal imaging, so MRI, CTs, in a 1,000 patient group population who have no back pain, no leg pain, nothing at all. Point 4 is educating the patient and giving the patient advice. So recognising that low back pain, non-specific low back pain, actually is completely resolved or significantly improved within 2 weeks. So empowering the patient, encouraging self-management and movement with a graded return, trying to prevent women from taking time off work or limiting the time they need to take off work where possible. Referring on for physical or psychological interventions, and reiterating that multimodal approach and making sure women understand that, rather than them perceiving that we're suggesting their pain isn't real or that we think they have a psychological illness. And then remembering judicious use of pain medication. So really simple analgesia, looking at Panadol, think about deep breathing, heat packs, some of those really simple pain management strategies. And then organising timely reviews and further referrals if needed. Now, I also just wanted to touch on this diagram you can see on your screen, which, if you look at the right-hand side, just is a diagram from Barton et al.'s 2017 article looking at the diagnostic triaging for low back pain, just highlighting that 90 to 95% of cases are actually non-specific low back pain, with that really positive prognostic that I just mentioned earlier. There are 5 to 10% of radicular syndromes. And I want to just point out here that the guideline actually still recommends conservative management as first-line treatment for patients with radicular pain presentations. So, and not doing any imaging until the patient's trialed a period of conservative management, unless, of course, the symptoms are rapidly progressing and there's neurological changes. And then serious spinal pathologies make up less than 1%. So just keeping that in the back of our minds when we're dealing with women presenting with back pain, and remembering that although these women are pregnant, they're still very much capable, strong, independent women that we need to empower rather than wrapping in too much cotton wool. So keeping them moving, keeping them exercising, keeping them confident. So key considerations with this, and it all ties back, you can see here, so ruling out specific or serious causes, providing that education and reassurance, encouraging movement, finding movements that the woman feels confident with, and working in to build up from there. The simple analgesia we talked about, not imaging unless obviously you think there's something serious. In terms of urgent physio referral, you can give the woman our contact details or the referral and she can contact us. You can fax that through with urgent on it and we will be in touch with the woman as soon as we can. We have physios on the ward that we can get to see women who are presenting urgently. We also have lots of reschedules naturally with, patients just I'm sure you all have the same thing. So we can slide patients in and we're very happy to see these women in a very timely manner because we understand the importance and significance. And then just reminding, and particularly even for us as a department, we forget to use really helpful fact sheets so that consolidates everything that we're telling these patients that are presenting as well. So this is one from the ACI, and it just touches really nicely on all those points that we've discussed.
Now, just another little pointer to some myth busting, or so maybe just addressing of some newer things for the management of pregnancy-related pelvic girdle pain. So really briefly, we've got the pelvis. It's made up of two innominate bones, the sacrum and the coccyx. There's the two SIJs on the back, the pubic symphysis joint at the front, and it's a common source of pain during pregnancy. Surprise, surprise. We're very aware of the lot of external supports that have come onto the market over the last few years. And I think what we wanted to do with addressing that is obviously we know that first line management is an individualised assessment and a tailored management plan from there on. We do know that there is obviously a need for giving women belts or suggesting belts at a time, and that we completely understand that for some women it may provide pain relief in a timely manner until they can get to proper care or to an individualised level of care. Now, pelvic girdle pain disorders are often associated with either excessive or insufficient motor activation of the lumbopelvic and surrounding musculature. And so that's why some ladies that you give a belt to may have a really, really awful response and others might have a really, really great positive response. What we want to say is the pros of the belt is obviously the patient preference. So some women do really benefit from it and it may reduce their pain in the short term. But when we think about the bigger picture, there is a cost associated. And for the women that are already fearful of moving and exercising, that extra bit of, I need this support around me might be reinforcing those fear-mongering behaviours, that they have a stabilisation need around their pelvis, which we know is not true. It does reduce their motivation to exercise as the pain improves, and it does not fix the biomechanical impairment or the maladaptive behaviours that have actually led to that pain to present in the first place. And in some instances, it can be quite uncomfortable, in which case adherence is low. So support belts are fine. You just have to pick your patients and, you can see how they walk into the room. You can see by the language they're using. But I think really, really importantly is that when you do give a belt, give a referral as well. It could be to a private, to a public physio, but get them to have that long-term sort of management to prevent that pain from coming back. And we talk about this in terms of, is there any birthing implications? We have patients who will be given a belt really early on, be okay, and at 35 weeks, pain's back. And unfortunately, it's quite hard to retrain motor development, fix the motor, like the biomechanical cause for that pain at 35 weeks. And then there's this whole prep of how we're going to get you ready to be able to be confident in the delivery that you're about to have. So I think it's really good, even if it's a session or two, it could be really low, but empowering that exercise prescription early on. And that brings us to our third out of fourth call to action. So let's all move around. Maybe let's do some shoulder or arm swings, whatever you like. Almost there. So again, you can feel free to keep standing or if you can sit down. For this, our call to action, and that it ties into the question that was asked a little bit earlier regarding if a patient isn't tied into Embody. Embody is the first point of call, but we also now have an antenatal drop-in clinic that runs in the outpatient department on Wednesday and Friday afternoons. It's a service that we brought into place to allow women who have low severity or bothersome symptoms, for those that just have questions for a physio, constipation management, or those that have a history of stress incontinence or back pain. It's not for referrals where they may be really, really distressed and need a bit more time and comprehensive review, where they're really debilitated by their symptoms and they can't carry on with their day-to-day. For those, like Kelly said, you can either call us or send through an urgent referral and we'll fit them in. However, for all the rest, so every Wednesday and Friday afternoon in the antenatal outpatient department from 1:30 till about 3 o'clock, ladies are able to present, say they're dropping in to see the physio, and that's where a lot of the motor birth questions and considerations can come into place. So it is shorter appointments because it's a drop-in style, but they will get brought into our service and then managed accordingly. So we may ask the women to come back to that drop-in clinic, we may get them to go to outpatients, or they may be fine and carry on with their Embody from there. And we'll take questions for that service at the end if you have any. But basically the call to action for that is you just tell them about that service, they can drop in and go from there.
Yeah, any Wednesday or Friday afternoon they can drop in. And if you're unsure, you can always send a referral and we can direct them in the right way. So moving on to postnatal, we're nearly there. I will just speak to the postnatal arm of our Embody program, so which is titled Embody After Birth. And essentially it's the same concept as our antenatal arm, Embody Pregnancy, however explores postnatal topics at the right time points or the relevant time points for women after delivery. So we look at that early recovery after delivery. We look at diastasis rectus abdominis. We look at return to exercise, return to sex, pelvic organ prolapse prevention and symptom management, as well as preparing for subsequent pregnancies. And essentially you've just stood up. If you want to stand up again, go for it. But it's the same concept as Embody Pregnancy. So just let women know about Embody After Birth, that they will receive a text message with the link. We take the birth register list from the Royal, and all of the women who birth at the Royal are invited to attend. And there's a little sticker on their Blue Book, on Bub's Blue Book, with all of their appointment dates and times, and that's updated each week. So we do them in groups of like a week period. So all the women birthing in that week get invited to said class and so on. So if they need any reference points, Bub's Blue Book will have a sticker on it. It's got our phone number on that sticker as well. But essentially that's first port of call. We will discuss another service in a moment, but essentially similarly to Embody Pregnancy, it has a self-referral. It has a survey that's really short that will act as a referral for women as well. So if they've got any concerns after birth, Embody's first point of call, particularly obviously if they're low bother, if they're really severely bothered, fecally incontinent, etc., then send them straight in. But for those low bother things, Embody, and women can actually self-refer to our service from there.
Okay, and last but not least, we're going to touch a little bit about on abdominal separation. So will exercise in pregnancy make my separation worse? Will sit-ups after birth make my tummy separation worse? And that's common questions I'm sure you guys may get, or we do get all the time. We're just going to go a bit of a review about abdominal separation. So the Swedish National Guidelines for the management of rectus abdominis states that gold standard for measurement, if we are going to assess, is going to be a caliper for distance. That diagnostic imaging by ultrasound or other imaging modalities should only be performed when concurrent umbilical or epigastric hernia or other causes of the patient's symptoms cannot be excluded. So we are not to do any imaging otherwise. Physiotherapy is first-hand treatment for diastasis of the rectus abdominis muscle, and surgery should only be considered in patients with functional impairment and not until the patient has undergone a standardized 6-month abdominal core training program. And yes, that's 6 months, so not 6 weeks, which is commonly what we get. A little bit about exercise. So abdominal exercises are first-line treatment, as mentioned, and they're first-line treatment they've been demonstrated to reduce the distance between the rectus abdominis muscles. Exercise during the antenatal period reduced the presence of separation by 35% and suggested that the width may be reduced by exercising during the ante and postnatal periods. And that was by Benjamin in 2014. So women who exercised during pregnancy, there was a 12.5% prevalence of separation. Non-exercisers was 90. And again, we take you back to what happens in the antenatal period is really, really critical in that postnatal outcome and journey. Another study looked at postnatal outcomes for the exercise and non-exercise group and found that above and below between. Now, abdominal belts and binders, which is probably another question that many of you may get asked is, can I use a binder? Will it help? What should I do? Will it make my separation go back to what I was pre-pregnancy? Binders, similar to our pelvic belts, a study looked at a belt versus belts and exercise, and the exercise was 3 times a week for 6 weeks, and it showed that the separation improves significantly with exercise only. I guess our key messaging for binders is, again, I think it's about picking your patients, but I think when you know the knowledge of what is actually effective, in the antenatal space, it's all about the education to the patient and the benefits of exercise. So, it's about the buy-in. So if it means that their separation might be maybe a bit better postnatally, you give them that, and you don't have to guarantee it, but you can sort of, wave the little flag around there and see if they might buy the exercise pathway then. Belly bands are a Band-Aid solution to provide comfort but do not assist in muscle activation. And again, in bodies, it really encouraged. We do essentially whole body exercises that target abdominal strength during Embody. In the postnatal space, again, Embody, we do provide exercises, reassurance, and education regarding natural recovery and prognosis, as well as the role of exercise. And this is speaking about those where we don't think there is a hernia. So anyone else that has a separation. Key points around this is that reassurance is key. Often women just need to be counselled on what has happened, why it has happened, and to normalise it as part of the pregnancy and the postnatal journey. And that with exercise, we're not trying to reduce the separation, even though studies do demonstrate so, but we're trying to improve function. So I often ask, are you able to empty your bowel? So can you create enough intra-abdominal pressure to empty your bowels? Because if you can't, that's a concern. And are you able to do what you need to do? Can you lift your washing basket? Can you lift the pram? And if they can do those things well and they're not having lower back pain concerns or other concerns, then they just need to attend Embody and be aware of the timeframes and the timelines for recovery. And so last but not least, our last clinic that we wanted to call to action is our follow-up after birth clinic. Now, Embody is for anything that's musculoskeletal, pelvic floor, but generally it's just a bit of a pathway through to the later stages of that postnatal journey. Our FAB clinic started off as a forceps clinic many years ago, but was soon transformed into a follow-up after birth clinic. And the reason for that being the number of forceps births make up a really tiny proportion of all births at the Royal. And if we were to only see a woman who had a forceps birth, we'd be missing a whole lot of people that have a whole lot of other symptoms that is not dependent on mode of delivery. So we've changed it from a mode of delivery focused clinic to a woman-centered clinic. The inclusion criteria for this clinic is women who are symptomatic of pelvic floor dysfunction. It is a joint clinic, so it's between physios and the medical team. And so if there is any wound concerns or suspicion of infection, that they can also be referred and they'll be reviewed by one of the medical team members. If women have any psychological distress relating to their experience, or if they've been picked up on the Embody survey, which is why we say Embody is your best point of call, because through the questionnaire, anything or any concerns they have will be picked up. Exclusion criteria for the clinic is women who have no bother and who do not consent to the appointment. It goes without saying. When vaginal heaviness is a sole symptom in the immediate postpartum period, and the reason we say that is often that does improve with time. But if after around 6 to 8 weeks they still have that as a concern, then by all means you are able to refer. And musculoskeletal pain, which is, again, you can do a direct referral to our outpatients for that. So our last call to action, maybe in your chairs, you can just do a few shoulder rolls, a few head rolls, is the call to action for our follow-up after birth clinic is essentially if you have any women that are sitting in front of you that are really, really distressed, write a referral. The way you can write that referral is to the antenatal outpatient department, and you can address Dr. Sarah Lyons because she is the medical consultant on that clinic. So it runs concurrently with our Oasis clinic. You can also send the referrals to our department, but they may very well be directed to this clinic before our outpatients. If you're unsure, ask the woman to join Embody and do a self-referral. But if you do have someone sitting in front of you with distressed pelvic floor symptoms, then please do refer to that clinic and they'll get seen normally between 4 to 8 weeks. In that clinic, we see women up until about the 3-month mark, but there are exceptions to the rule. And that brings us to the end of our talk. So...
Thank you, Kelly and Kimia, for a very engaging presentation. There's quite a lot of online questions. It's going to be really difficult to tease out a couple. So we'll just do a couple of online questions and then we'll move to the audience. Yeah, one of the questions is, can antenatal patients not delivering at the Royal Hospital for Women but living locally access Embody and the other public physio services at the Royal Hospital for Women?
That's a great question. I've just taken this off so that I can hand it over. At present, we are certainly inviting all of the women registered to birth at the Royal. We recognise that women, maybe birthing privately might have other healthcare options. But I think as a public service, certainly for a woman's really keen, really engaged and wants to learn about her health, then certainly you're welcome to send through an email. Or ask the woman to reach out.
Another question is regarding, I guess, the slide you showed with women coming to the gym. I'm more for the postnatal services. Can they come with their babies? Can they attend postnatal physio classes with their little ones?
Absolutely. So more of our exercise, so obviously the gestational diabetes in the gym face-to-face is during pregnancy. We have toddlers in there, so even if women in pregnancy want to bring their toddlers, that's okay. In terms of follow-up after birth clinic or Embody after birth, obviously the women are welcome to bring their babies to any of the physiotherapy appointments, and we accommodate that because, of course, it's very reasonable that women have caring duties and often there's busy lives, partners might be at work, whatever that looks like. So absolutely.
Just one last question. Please, can a physio make it clear or outline how to refer to each clinic and what each clinic is for and when the drop-in clinics are, as I'm now much more confused than when I was before this talk.
Oh,
Sorry.
Very valid point. I think as long as you, I think we've tried to make it as clear as can be, and that's the matter of the fact is that we're trying to, in regards to the first 2,000 days framework, make care accessible, and that means that there is going to be multitude of pathways. I think if you take anything from today is to just refer to outpatients. If you do it wrong, it's fine. We will triage accordingly. And the more information you pop on that referral, the more that we can get. And if we get a referral that we're unclear about, we will call the patient and ask, what is the presenting concern? I think the biggest call to action for today is the GDM and the preventative, because these are the women we're just not seeing. Like, we just can't get them any other way. You guys are are our key to that. But anyone else, in terms of management, to the drop-in clinic, to the outpatients, to the follow-up after birth, to Embody, just tell them to go to Embody, and then everything else will come from there, because I'll do the questionnaires or just write a referral otherwise. So GDM, referral to outpatients, Embody. Hopefully that makes it a bit more clear. So you can definitely, so we get plenty of referrals from GPs. You can just write to the physiotherapy departments at the Royal Hospital for Women, and we get plenty all the time. But the more information you provide on that, the better we can triage that patient into the right clinic or service. As long as we get it, they'll be in care.
Just, it's highlighted on, I think, that antenatal drop-in clinic slide. We acknowledge there's lots of different services and streams, but don't overcomplicate it. If you're unsure, if the patient's unsure, pop a referral through. Maybe the patient's already enrolled in Embody, but we just need to call them and talk them through that, and that's absolutely fine. So if you're unsure, just send it through, screen those high-risk GDM women, and we will sort the rest out. That's absolutely fine.
Fax number, or who do we actually physically send the referral to, and how is it online?
Yeah, so same way that you'd send referrals otherwise to other clinics. So the fax number and for our department's on the website, but we might be able to have some information or resources sent through. But you just fax it through, and we get faxes every day from GPs and specialists coming through. It doesn't have to have a certain name, if that's what you mean. No.
Just for those online, that was a question about what's the best way to fax it through. Correct me if that's wrong. What's our actual fax number and contact number there? And I think we've just noticed that it's not on the GP shared care protocol list, but we will work with the team to distribute that. Sorry. Yeah, we can send it through with the slides. Absolutely.
Sorry, was there another question? I think someone up.
Yeah.
Fabulous. So that was a question about how to refer to Embody. If you're getting women early before they've come through their first appointment through the hospital, you just tell them about it and they just click yes. So women are given the option to opt in or opt out. So they just need to know what it is. Half the time we're finding they just don't know, so they say no.
Correct. Yeah, it's on the bottom of the online booking form. And I think the common factor we find is that women call us saying, I've just got this text message. I didn't know I registered for this. So if the more information that they hear about this program, because then when we explain it, they go, oh, great, I absolutely want to do that. But understandably, if you're getting a text message you weren't as aware of, then you're less likely to attend. So it's just that improving their knowledge of the service factor there that would be super helpful.
Let's get one more question. There's some devices you can use later in pregnancy to reduce pelvic floor dysfunction postpartum. Do you guys recommend those things?
Are you speaking specifically about the Epino? Yeah. Great question. Debatable, very controversial point of like the new maternal care services and all the other products coming out. I think the evidence for perineal trauma and like prevention of perineal trauma states with perineal massage and pelvic floor muscle awareness. So That's where our Andy clinic and the drop-in clinic is really great, because if you have a woman that's distressed, that's not feeling comfortable in having a vaginal delivery because of fear of perineal trauma, that's when from 34, 35 weeks onwards, getting them to do the correct exercises, starting the perineal massage, which is all covered in our body, is actually the way to go. And the evidence behind that is stronger. And that's all I can comment on. Epinode does have a few bits of research out there, not too promising, but like all research, it depends on population, the intervention, all of that. But what we can speak to is the perineal massage and the awareness exercises.
I think reiterating that, and you know, it's up to the woman if she feels like she's uncomfortable with perineal massage, and that's something that absolutely could not be done, but an epinode was something that makes that accessible. You know, maybe there might be a role there, but certainly there's the financial cost, there's the equipment need, et cetera, et cetera, et cetera. When it's, as Kimia just touched on, there's lots of really strong evidence that you don't need these devices and equipment to achieve the outcome.
Okay, well, thank you to you both for coming to talk to us today. Please accept these gifts as a small token gesture of coming today.
Thank you so much.
So just a quick roundup. Thank you to all of our speakers and to all of you for attending, especially on a Saturday afternoon.